Namaskar and a very warm welcome to everyone. It gives me immense pleasure to be part of the inauguration of Pan Ophthalmologica 2025, a truly global ophthalmology webinar that brings together some of the brightest minds in eye care. This year's event is remarkable in its scale, with participation from over 45 countries across 9 virtual halls, representing 7 ophthalmic super specialties, featuring more than 250 expert faculty and 30 plus sessions of shared learning and innovation. Such a collaborative platform reflects the true spirit of global healthcare, where knowledge knows no boundaries and where expertise is shared to serve humanity in a better way. SBI Foundation believes that good vision is the foundation of good quality of life. Through our community health initiatives, we continue to support programs that make quality eye care accessible and affordable to all sections of the society, particularly the most vulnerable and the underserved communities. Such events strengthen this mission by ensuring that knowledge, technology, and compassion come together to prevent avoidable blindness and enhance community ophthalmology across the world. I extend my heartiest congratulations to the organizers, the faculty members, and the participants for creating such a meaningful platform on the occasion of World Sight Day. May the discussions today inspire new partnerships, innovations, and pathways towards building a future where no one is left in the dark. Thank you very much. Jai Hind.
First of all, let me welcome all the speakers and welcome to Pan Ophthalmologica. And it's my great pleasure to present to you this session in Hall H. And we're going to have an array of great talks. And we're starting with Dr. Tulsi Das. Thank you for waiting. And I think the stage is all yours. Please go ahead. You can share your screen, sir.
Yeah, thank you, ma'am. Is it visible?
Yes, please go ahead. Clear.
Good evening, all. So today I'll be talking on approach to primary angle occlusion disease. This presentation will just cover the basics. I'll be discussing 3 simple cases, followed by a brief discussion. So I would like to thank the Sethi family for giving me this opportunity. So the case 1 is a 60-year-old woman who presented with blurring of vision in right eye since 6 months. She had previous episodes of recurrent redness and pain over 2 years. So in the right eye, the corrected distance visual acuity was 6/18 with an IOP of 28 millimeters of mercury. And in the left eye, the vision acuity was 6/6 with a normal IOP. Now on slit lamp examination, as you can see in the figure 1, that is in the right eye, the anterior chamber is shallow with loss of pupillary rough and a few atrophic patches and subcapsular opacities suggestive of glaucom flecken, all these pointing towards the possibility of previous episodes of angle closure attack. Whereas on the left side, you can see just a shallow anterior chamber and the rest of the examination was within normal limits. On gonioscopy, 360 degrees of occludable angles was observed in both the eyes, whereas on indentation, 1 quadrant opened up in the right eye and all the 4 quadrants opened up in the left eye, indicating a synachial angle closure in the right eye and an apostral angle closure in the left eye. When you see the fundus picture, in the right eye, the disc is moderately sized with a classic inferior neuroretinal rim thinning with a cup-disc ratio of 0.6 to 0.7, whereas in the left eye, it's a normal disc with a healthy neuroretinal rim. On visual fields examination, you can see in the right eye there was superior arcuate scotoma and an inferior nasal step extending to the arcuate area, giving a mean deviation of minus 16 decibels, pattern standard of 11 decibels, suggestive of advanced glaucoma, whereas in the left eye, the visual field was normal. So this gives a diagnosis of right eye advanced primary angle closure glaucoma with immature cataract and left eye primary angle closure suspect. So the treatment plan would be a right eye phaco trap with mitomycin C and a left eye prophylactic YAG-PI to avoid the attack of an acute angle closure. So I'm just giving three simple, straightforward cases, then I'll be just going to the discussion. The second case is a 58-year-old woman who presented with headache and eye pain since 3 months, repeated episodes associated with nausea sometimes. Visual acuity was normal, but yeah, the patient is hypermetropic. The intraocular pressure was 24 millimeters in right eye and 23 millimeters in the left eye. The anterior segment examination showed a grade 1 Van Herrichs with a clear lens, and the rest of the examination was within normal limits. So on gonioscopy, again, you can see 180 degrees, 270 degrees of occludable angles in the right eye and in the left eye, which opened up on indentation suggestive of an appositional angle closure. And as the IOP was high, we can give the diagnosis of primary angle closure as per the ISGO classification. And in this case, an ideal treatment plan would be a laser peripheral iridotomy. Now coming to the third case, which is 66-year-old woman who presented with blurring of vision in both eye with episodes of headache over a year. And she was diabetic for 5 years. The distance visual acuity was 6.9 in both the eyes with plus 3 diopters. The intraocular pressure was 21 millimeters of mercury. Now the anterior segment examination revealed a shallow anterior chamber and a nuclear sclerosis grade 2 with a normal fundus picture. On gonioscopy, again, you can see there is occludable ankle which open up on indentation suggestive of an appositional angle closure. Now I've dilated the eye, I've done a provocative test also, and the IOP after dilatation was 22 in right eye and 21 in left eye, did not increase much. And the pachymetry was 511 in right and 512 in the left eye. So in such cases where it is an angle closure suspect, but with significant cataract, I would prefer to directly go ahead with the phacoemulsification or the cataract surgery rather than doing a peripheral iridotomy. And after the surgery, you can see the vision also improved to 656 and the IOP has come down to normal range, that is 17 in right eye and 18 in the left eye. So now with these three cases as a base, which I just pointed just to give a routine case of each subtype of primary angle closure glaucoma. So as per the 2020 global estimates, the angle closure glaucoma constitutes 25% of the total glaucoma. But when it comes to the ratio of blindness, it is almost 1:1. Both angle closure and open angle glaucoma are equally responsible for blindness. When it comes to the risk of severe bilateral visual impairment, the danger is more with the angle closure, that is almost 3 times more with angle closure rather than open angle. Now, on this World Sight Day, it is important to create awareness regarding the importance of early diagnosis and regular follow-ups to prevent the reversible vision loss due to glaucoma. Now, around 23 million people are affected by angle closure glaucoma, which is supposed to rise by 32 million by 2040. Now, this is a normal mechanism, as we all know. So there is a posterior pressure, high post pressure in the posterior chamber, which actually pushes the iris forward, causing a bowing of the iris, and which blocks the ankle and the trabecular meshwork. So this happens due to three mechanisms, that is mainly the relative pupillary block, or else a plateau iris configuration, or else lens-related problems. So the risk factors include a shallow anterior chamber, shorter axial length, thicker iris or lens, or an anti-rotation of the ciliary body. Emotional stress, nervous individuals, flat-silver, dim light are all risk factors. Now, like I said, these are the three major mechanisms where a patient can develop angle closure. The first one is the most common, that is the relative pupillary block. So when you put anticholinergics or any other mydriatic eye drops, You can see there will be a mid-dilated pupil, which actually causes a high pressure in the posterior chamber, blocking the aqueous to come forward, causing bowing of the iris and blocking the ankle and the trabecular meshwork. The second one could be the plateau iris, where usually the limbal anterior chamber will be shallow, whereas the central anterior chamber depth will be normal. Now, the classic presentation of a double hump sign on gonioscopy gives you the hint of plateau iris configuration, where the central hump is due to the lens and the peripheral hump is due to the ciliary process. The third one is a lens related, mostly due to a thick lens, which we can actually diagnose based on the lens fault, which is calculated when you draw a perpendicular line from the scleral spur joining the both sides to the anterior pole of the crystalline lens. So anything more than one corneal thickness, more than 550, or in different studies, as we say, more than 600 microns, is indicative of a high lens fault, which can actually predisposed to angle closure glaucoma. Now, what will happen once an acute attack happens? So initially after the acute attack, the RNFL thickness will be increased in the first few days, and this will be little misleading for the general ophthalmologist if they just do an RNFL at 1 month or something like that. And then the axonal swelling resolves at approximately 1 month. It comes to the average thickness, and the actual axonal atrophy happens after 1 month. And the thickness decreases at 3 months. So this is the importance of a regular follow-up in all these cases, even after doing a laser peripheral iridotomy. Now, as per the International Society of Geographical and Epidemiological Ophthalmology and World Glaucoma Association, the primary angle closure disease is classified into three subtypes, like I discussed in the beginning, three different cases, each belonging to one subtype. So the primary angle closure suspect is basically an iridotrabecular contact of more than 180 degrees with a normal IOP, no pass, and no optic disc damage. Whereas in PAC, you will have an elevated IOP or an evidence of PAS along with an iridotrabecular contact. In PACG, we tick all the boxes, that is including a glaucomatous optic disc. So gonioscopy is still the gold standard, preferably indentation, and ASOCT and UBM can be supportive. ASOCT is mainly useful when you actually compare the pre and post-op picture after an iridotomy, and also when you want to counsel the patients and when you want to document it, showing the patient like how it really looks like, because most of the time the gonioscopy picture uh, is very difficult to capture and we cannot show that to the patient. Now, UBM always help in rolling out the secondary causes like ciliary body cyst, iris cyst, or even aqueous misdirection. Now, as far as the present literature is concerned, the provocative test, that is a water drinking, the darkroom prawn position, all these are not specific methods for a diagnosis of angle closure glaucoma. These are the major RCTs involved with PACD, which is comparatively a fewer one, like compared to open angle glaucoma. We have the major three RCTs, that is Songshan Angle Closure Prevention Study, which was conducted in 2023 when they had the final outcome, that is over 14-year outcomes. Then we have the Singapore asymptomatic narrow angle laser iridotomy study in 2022 and the much controversial Eagle study in 2016. Now, as per the ZAP study, even though there was a reduction in the progression of cases to primary angle closure after a peripheral iridotomy, we need not perform the iridotomy at a community level in all suspects. So as per the study, around 33 patients in the treated eyes and 105 patients in the control eyes developed to PAC. One went for an attack in the treated eye, and 5 went for an acute angle closure attack in the control eye. And 2 developed angle closure glaucoma, 4 developed angle closure glaucoma in the treatment and control group respectively. So this gives a clear picture that laser peripheral iridotomy, though reduces the chance of progression to PAC or PACG, should not be performed in all cases of primary angle closure suspects. So you can keep strict guidelines like in which all cases you want to actually perform peripheral iridotomy. The analysis study also gave a similar outcome, like the reduction of progression by around two-thirds after doing an iridotomy, but still it need not be performed in all the cases. Now, the Eagle study is little controversial because it has significant limitations. So at least in our country, we don't propagate this clear lens extraction as an alternative to peripheral iridotomy. But yes, in cases with early lens changes, you can consider lens extraction instead of peripheral iridotomy, and which can give very good visual acuity and outcomes for the patient. Now, what is the treatment options available? So we have the laser peripheral iridotomy, which is a way to go in a primary angle closure glaucoma. When? So acute angle closure crisis, primary angle closure, and primary angle closure glaucoma. It's a definitive indication. And like I said in the previous slide, when it comes to PACS, these are the criteria which should be considered when you're performing iridotomy. So it should be either a one-eyed patient or the contralateral eye of a patient with an acute attack, or if the patient had to undergo repeated dilated examination for any retina pathology, family history of glaucoma, or if the patient cannot follow up, if the patient is coming from a faraway place, you can still consider. And last option, when you actually discuss with the patient whether you want to get it done, and if the patient feels getting a PI is better, then you can definitely go ahead. Now, in plateau iris syndrome, that is in a plateau iris configuration, if you have recurrent high IOP despite doing an iridotomy or lens extraction, we call it as plateau iris syndrome. And we usually perform peripheral iridoplasty in these cases. And in my experience, it is found to be really useful. Now, all the anti-glaucoma medications can be tried if it has gone to the stage of primary angle closure glaucoma. And surgery, like I said, the lens extraction can be definitely given if it is an early cataract or even if it is an early glaucoma. A pure phacoemulsification will give you the adequate result instead of anti-glaucoma surgeries. Now, MIGS, though the real consent is not given, can still be combined with phacoemulsification in these cases, or else, at least in cases of early to moderate glaucomas, you can still go ahead with MIGS. But definitely, TRAP should be the way to go in advanced cases. Now, this is one scenario where most of us will be a little confused, mainly the general ophthalmologist, when a primary angle closure disease develop along with a visually significant cataract. So in my experience, in PACs and PAC, you can just go out only with phacoemulsification and follow it up. Even in cases of early glaucoma, you can either go with phacoemulsification alone or a combination of phaco with MIGS and follow it up. But yes, when it comes to moderate to severe glaucomas, definitely you have to do a double procedure or a combined procedure, either a phaco trap at one sitting or a phaco followed by trap at two different sittings. So the take-home message is history is very important in all glaucoma cases, because when a drug-induced angle closure glaucoma will be missed out if you don't take the history properly, and also previous episodes of similar acute attacks should be considered. Gonioscopy is essential and is still the gold standard. Laser peripheral iridotomy is the first treatment of choice, not in all PACS, but in selective cases. But yes, definitive indication in acute angle closure, PAC and PACG. Lens extraction does have a role when it comes to early cataracts, and if you can actually discuss the possibility of visual improvement with the surgery, provided the surgeon is skilled and is experienced. And TRAP should be performed in moderate to advanced angle closure glaucoma cases without any doubt. Thank you. Thank you for your kind attention.
Thank you so much, Dr. Tulsidas. That was a very remarkable, comprehensive overview, and I know that it's not child play to actually concise PACD because it's such a vast topic. So, just for the benefit of general ophthalmologists, I have one question for you that you can answer very quickly.
Yes.
That what special precautions would you take when you're doing a combined phaco trap, as in a trabeculectomy done in an angle closure glaucoma? Will your surgery be modified in any way? Will you be taking certain precautions? Are there certain specific complications you're more worried about?
Yeah, definitely. So the incidence of post-trap complications or post-glaucoma surgery complications are more with an angle closure subtype rather than an angle open subtype. So we have to make sure that the patient does not go for a hypotonic soon after the surgery. So we have to, it is remarkable and it is, if possible, it is better to put releasable sutures in all these cases. So you can actually titrate the IOP post-operatively. So hypotonic, choroidals, choroidal effusions, all these things should be taken care of. And intraoperatively, yes, there's a high risk of suprachoroidal hemorrhage. So you should be aware that when you're taking such cases for surgeries, the initial preoperative IOP should not be very high. You should try to control it to some level using conservative measures and then take the case. So I would preferably say something in 30s would be an ideal rather than going straight for a case with more than 40 millimeters of mercury. And yes, meticulous planning, including osmotic drugs and intraoperatively using mitomycin C, the concentration depending upon the cases, the duration depending upon the cases, and releasable sutures so that you get to a chance to titrate the post-operative IOP, and that will help to limit the complications associated with traps.
Thank you so much, Dr. Tulsidas. Thank you so much for your time and effort.
Thank you. Thank you.
I'm going to take this opportunity to invite my next speaker. He's none other than Professor Ethan Blumenthal, and he currently chairs the Department of Ophthalmology at the Rambam Medical Center, Haifa, affiliated with the Tekoin Medical School. Professor Blumenthal graduated from Jerusalem and completed his residency in ophthalmology at the Hadassah University Hospital. He then proceeded to specialize in glaucoma at the Glaucoma Center of the University of California, San Diego. Upon returning to Israel, he headed the glaucoma service at Hadassah Hospital. Dr. Blumenthal specializes in operating complex glaucoma and cataract cases and in early diagnosis of glaucoma. His research encompasses imaging of retinal nerve fiber layer and optic disc, the structure function correlation in glaucoma and medical technology, and he's developed the Vogt Blumenthal suturelysis lens and the Katina Blumenthal conjunctiva dissector. So it's my absolute pleasure to invite Dr. Blumenthal to take over the stage and give us his insights on his topic, which is, are we operating too late?
Hello, everyone.
Hello, Dr. Blumenthal. Welcome. Your screen is well visible.
Great. Is it in shared screen mode?
Yeah, you need to get into the screen, the bigger
Okay,
screen.
great. So my talk is a little different. I'm not going to share evidence-based, multicentral data, but try to think aloud. And I think meetings should not only concentrate on what's already proven and definite, but also to stir our imagination, our directions, and in this case, our frustrations. First, I'd like to thank Dr. Arun Sefi for inviting me to this very interesting and global sharing of ideas. And my topic today is, what should be the indications for glaucoma surgery? Two questions include, why are we occasionally operating too late along the course of the disease? And I'll talk a lot about that. And why do some patients slip through the cracks? When I say occasionally in some, I think the problem I'm going to address is far worse than what these minimizing words imply. The first three examples are all real patients. That's real patients that walked into my clinic. To summarize the topic, I'm raising a question. We usually operate patients when we see progression in their visual field, and you may also say in their imaging. I'm questioning whether the indication for surgery should be the amount of damage as opposed to the actual proven progression. And I'll explain about that. This is a patient that came to me in 2011, and looking at the data in 2007, one medication, pressure 16, you can see the grayscale on the left, looks nothing to write home about. 2009, 3 medications in ALT were written, and in 2011, he referred to surgery. I think we can all agree that this patient was referred to surgery way too late. I would probably say that this is borderline a blind eye based on our criteria in our country. Should we have done something different here? Second patient, 10 years ago, young 48-year-old person, good, excellent, good vision. IOPs look fine on maximal tolerated medical therapy, never operated. He's been followed up for 5 years, and the doctor referred him for stable visual fields and good IOPs. So on first glance, why did he even refer this patient to me? So this is what the discs look. You can see just a tiny bit of nasal rim present. This is the right eye visual field. And he wrote to me, he's perfectly stable. I didn't know if to laugh or to cry. And just to make things a little bit worse, this is a stimulus 5. You should all say, oh my God. And this was the right eye visual field 10-2. I don't think I've ever seen a worse, very good seeing eye in my career. Left eye stimulus 5. Left eye stimulus 10-2. So that's the second patient. And now this is the third patient. Excellent vision, 20/25, excellent IOPs on maximal drops, no prior surgeries. What do we do? What do you do with this patient? So a year from now, it's not only likely, but probably definite that in the next 2 years, the vision will drop to 2200, the pressures will be fine, and the patient still had no prior surgeries because he didn't have them until now. And these are all patients that were followed. They did not just come down from the airplane from Mars. So do we operate or do we not operate, and when? So I'm going to do something that I call reverse engineering, and we'll see where this gets us. When we think about the battle against glaucoma, it's an ongoing battle, probably for the patient's lifetime. That's the ammunition that we have. We have medications, drops, tablets, lasers, MIGS, tube, trap, micro CPC. These are our ammunition. And in this talk, I'm being a little bit conservative in what I'm writing. Of course, we can update it to each and every one of yours preferred surgical techniques. Here, this is not a real patient. This is a continuum of glaucoma damage from different patients. And I tried to show how the visual field moves from perfect vision to no vision. And I thought, I tried to do it rather in like equal or plus minus equal steps. So now let's presume that everything failed and the patient went to total blindness. And we did try to do our best. So how would we spread our ammunition along the course of the disease? So look at this graph or this option, this algorithm, and tell me if it makes sense. Now, for the first time, you can see that we're not talking about progression, we're talking about damage. So the indication to do a procedure or to give a treatment here is based on how bad the visual field is, not on whether it's worse or the same as it was last year or 2 years ago. So take a look at it and ask yourself, is it okay? Is this doctor too eager to operate? Is he too relaxed? How does that work with your technique, with your understanding of glaucoma? So I think this is way, way too laid back. And why? This is probably what a lot of you would consider legal blindness, and based on visual field. And there's no logic in continuing to do surgeries after the patient is blind. We should push them forward, back, and do everything we can before we lose, not after we lost. So I tried this. And of course, we can do 1,000 trabs and 1,000 tubes, but I think 2 lasers, 2 trabs, a cataract, which is also, we know, good for glaucoma, 2 tubes, and then we lost the case. Makes sense that we can go home, sleep at night, and say, we really tried hard. That looks to me okay, but the question is this still laid back? Take a look at it. Treatment protocols differ, healthcare accessibility differs. Some places we lean more on drops, some more on surgery, but in general, take a look at it and ask yourself, is this how I would like to treat my patients? And the question is, does it make sense that we'll do the first surgery when almost all the top hemifield is wiped out? Is that okay, or is that too late? And even this scheme, I think, is way, way too laid back, which means we are operating too late. So how do we take all this information and transfer it to our general ophthalmologists in the community? Because we sit and we can help the people who referred. Most of the cases I showed you are people that were not referred to an ophthalmologist. So it's not just us needing to be less laid back, meaning waiting too long, in other words, but we got to communicate it to the community. And what I've done is I've designed an algorithm that has not been tested or validated, that conveys the issue in this lecture. I don't think you can start treating patients like this. I don't think this can be the way you determine what necessarily needs to be done to the patients. But I think it's a very, very good test to see how laid back are you in your clinic. And when you run it, you may find surprises. I guess that just about all of us are operating too late, including me. I'm the first to admit. The problem I'm referring to exists, in my opinion, in many, many clinics and healthcare systems I've seen, including me. So how does this algorithm work? It's very, very simple. You can teach it to a 4th grade primary kid student. You can explain it over the phone to your primary care physician. You can discuss it. And what I would recommend each one of you to do, take your secretary or do it yourself and just check the first 100 patients that go into the clinic and check how do you score on this little algorithm test. And how does it work? Only look at the 4 central points in the pattern deviation plot. You can see the red circle on the left, just there. And as you can see, disregard everything else. We're on the pattern deviation plot. Now, as long as all the 4 dots are normal, you can do whatever you want, medications, laser, anything you want or wish. However, if one of these 4 dots is black, one of these squares is black, on the right is what the visual field should probably look like. The patient must be after their first glaucoma surgery. If they're not, we're very laid back. I think this is a laid back algorithm, which means we should be much more aggressive than what I'm showing. But if we're not at least as aggressive or assertive as this, as they say, Houston, we have a problem. So this is the first point. When the second point is black, the patient must have had 2 surgeries. When the third point is black, they must have had at least 3 surgeries for glaucoma. And when all points are black, we lost. That's certainly not the time to wake up and say, oh, this patient needs surgery. This is game over. So I think this is a very, very laid back approach. But when I test the patients referred to me in my clinic, we're not meeting this criteria in many, many patients. So I would probably, if I wanted to be less laid back, I'd say once the first of the 4 central points are black, the patient should be after 2 surgeries, and then 3, and then 4. And if you want to make the algorithm even more sophisticated, you can start looking at the points on the second square, like the points 1 removed around these 4 points. But that starts getting a little bit more complicated. So thank you very much. Again, this is not proven or evidence-based, but it is a wake-up call to ask ourselves, should we operate earlier? Thank you very much.
Thank you so much, sir. So I have a small doubt. Like, you said that if there is a black dot on either of the 4 sides of the line of the deviation, then we plan ahead. Like, as you said that this is not a normal protocol. Like, how many patients have we tried this on, or is there any like number of patients that it's been tried on?
Again, there is a flaw here, and I'll try to explain it. First of all, this is like a guideline for me. This is not a protocol. This is not a protocol to make me decide what to do with the patient. This is a protocol like a lakmus paper to check how do I align against this algorithm. Like, are most of my patients operated before, within this guideline, or this like mathematical, check, or too late? It's like setting a post and asking myself, am I jumping further or shorter of the post that I put in the ground? So I can now go a little bit deeper about why I think damage and not progression should be the issue. If we look at the way we are taught to treat glaucoma, we see a patient, we think there is early glaucoma, it may be normal tension glaucoma, and we say we feel that this patient needs treatment. There's a lot of studies. We know all about it, and we decide to give the patient 1 drop. Then we follow the patient, and we look for progression, because maybe that 1 drop is enough. And once we find progression, we give another drop. And then, again, we have a white page, a clean slate, and now we're again looking for progression. And then we give a third drop, and then we do a laser, and we say, maybe the laser cured the progression. Now the patient has stable glaucoma, he will never progress again, and we start again. And then a year or two pass, and then we do another laser. So we're very, very laid back. Now, this is an ideal world because some patients are lost to follow up. Sometimes the doctors retire. Sometimes the patient switches a doctor. Sometimes the file is not accessible. And what we also do, we tend to look at this field versus the last field. And we say, oh, he's been stable since a year ago or 6 months ago. We don't look like 20 fields back unless we have a software that does it. You can say that on the Humphrey visual field, there's printouts that show you progression and so forth, but then the patient moves to another machine, he moves to another doctor. And eventually, when I see the patient, and so the patient to get to surgery or to get to the fourth surgery, they need to have shown maybe 9 incidents of progression. You needed to document 9 times that the patient has progressed inside a less than perfect world where data is lost and machines are switched, and now a new visual field comes around. It's another company. It's difficult to compare it to the past, the new OCT, and so forth. So at the end of the day, I see these patients with almost black visual fields, and they've all been followed. And I ask myself, what have we done wrong? And I think our reliance on the need to prove progression is the one thing that causes us to be so laid back. We say the visual field looks terrible, but I can't prove that it's deteriorated since I did the SLT 3 months ago or a year and a half ago, so I can't proceed with adding medications or treatment. And then you see what happens at the end. So, just think about it. It's just me. It's not the truth. But I hope that this talk will do 2 things. It will force you to ask yourself, am I too lean or too aggressive or assertive? I don't think aggressive is the right word because we all want what's best for our patients. So am I pulling the surgery out of my pocket too fast or too slow? And second, look at these very, very advanced cases and ask yourself, how is it possible that a patient that has a chart 2 inches thick or 2 megabytes thick and is being followed and did exactly what the doctor told him for 10 years, how is it possible that the visual field looks like this and they were never operated or barely operated?
Thank you so much, Dr. Blumenthal. That was indeed very enlightening. And I am so happy that you brought this issue forward because, I see it in my practice and it's a serious problem. And a lot of it stems from, the need for general ophthalmologists to retain these glaucoma cases. So I have cases referred to me all the time with such bad glaucomas that they're left with visual field index of 1% or 2%, and no one can really do anything about it. And I feel handicapped as a glaucoma consultant that I'm sending these cases away, but there is absolutely no way that I'm going to operate on such cases. So the message does need to go out to general ophthalmologists to know when to refer. And also another challenge I think comes in understanding fully well what progression means and how do you quantify it. So since there are no specific guidelines that are laid down, no mathematical calculation that we can do, it's very much the understanding of a glaucoma specialist or the ophthalmologist that's taking care of the patient. So even I think we should really also concentrate on understanding and educating general ophthalmologists on what exactly progression means, and not just following patients on the basis of IOP, because I've also seen these cases without any visual fields for 2 to 3 years and coming in with a full glaucomatous tunnel vision, and they are just being followed up with IOP, and IOP being 8 or 9, well, stable, doesn't need to follow up for the next 4 months, and then they land up on my lap. So yes, and I'm really happy that you've portrayed your talk in such a way that the message needs to go out to refer early to a surgical glaucoma specialist. So thank you so much for your talk.
One question,
Thank
Dr.
you.
One question, Dr. Blumenthal, for you and Dr. Saiba, and that is there anything like a prophylactic trabeculectomy? When we were medical students, most of the people in the village would not come again for treatment. So a lot of our doctors used to say if the pressure is 24 to 26 millimeters, better do a trabeculectomy and send them because they can't afford lifelong medication. They do not have access to that. Do you subscribe to that theory even now for people in rural areas who can't afford?
I'll answer it, and I have another comment. I'll do it really. I'll talk fast. Stop me if the time is an issue. Answering you, I've thought about a lot the question: is glaucoma a medical or a surgical disease? So we know that pediatric congenital glaucoma is a surgical disease. I don't think anyone would stand up and say, "I think that's wrong." I believe many of us think that juvenile is a surgical and not a medical disease. I'm going to say something that is going to turn and make this question irrelevant. My opinion is that every disease in medicine, if the surgical option gives better outcomes, it's a surgical disease. If a medical option gives better outcomes, it's a medical disease. And the most extravagant example is the peptic ulcer that switched from being a medical to a surgical disease, because from a surgical to a medical disease, because we found better treatment. So I think the patient you're describing in that setup, the surgical option is far better than the medical, which you said it's not really going to be medical. It's going to be medical for the doctor who sleeps at night and says, I did what I can, I did what's right. But if you push the doctor to the corner, and as I think I heard between or even in the lines, the patient is not really going to be on that medication. So certainly, I think, in fact, in Moorfield, there was a study where they said that let's treat everybody with traps. Let's not even start drops. And when you look at the study results, it made a lot of sense as far as the results at the end, complications and so forth. And they even claim that once you start drops with the patient, the ability to succeed with a trap goes down the drain, maybe from inflammation or scarring that is based on the drops. Do I have time for another comment?
Please go ahead.
Okay, I'll try to do it really fast. In my clinic, I've done something that I think 99% of the audience, I hope, and if somebody did, I'd really be grateful if they emailed me. I did something very dramatic, and I put a sign on my door that says, I'm not a glaucoma expert, I'm surgical glaucoma. If you think about it, it's exactly what happens in retina. We have medical retina and surgical retina. I decided to split up glaucoma, the glaucoma field, into two, and I'm going to be just a surgical glaucoma. The implication is that instead of having a 4, 5, 6 month waiting list like in all other hospitals in Israel, I will see a patient within a week. If a patient has pressure and needs surgery, I will see them within a week. And I try to switch my clinic to only be one pre-op visit, as many, hopefully 2, sometimes 8 post-op visits, and that's it. I don't see a patient. In fact, I have a rule. I'm not allowed to see a patient more than 2 months ahead. I will never write a 3-month or 6-month or 1 year reschedule. They will go back to the community. In this way, number one, patients with the need for surgery get very, very quick access. Number two, I do lots more surgeries, which is, first of all, why I trained. It's like, it's more fulfilling, it's more fun. It's even, I will whisper and say, it's even more profitable. And I will get better because the volume of surgeries that I do will be much higher. And remember that your volume of surgeries today has to be split into so many different surgeries of glaucoma. You know, you want to do trabs and eye stents and whatever, and XEN and GAT. So you need a lot of volume to be even okay at each of these surgeries. It's a lot more fun. I give a solution to the community, and I think that's the way to go. Any doctor here that has more than a 3-month waiting list, and he feels that he's seeing patients that the community could have seen, and it's not like a private clinic or whatever that there's complications, should put a sign on their door. I'm a surgical glaucoma trained physician. I'm like surgical retina. That's how I explain it to my colleagues that don't understand what I'm doing. And I only see patients that need surgery. And trust me, if you can do it, if you can set it up, you will really be grateful because you will feel so much more worthy when you come to work. Your qualifications and experience will be so much more utilized, and maybe even your salary will improve. But that's certainly not the reason. I'm saying it because it's always nice to think that you're not pushing back in that respect. So think about it, and if anyone has done it, tried it, like the idea, maybe a year from today says my clinic was changed. And the way that you should check it, you should check what is your conversion rate. If you have 15 patients in the clinic today, and out of them came 2 surgeries, that's 2 over 15, you calculate the percentage. If from these 15 patients you got 5 surgeries, you're at 33%, you will probably never go above 5 from 15, because you also see post-ops and not everyone that was referred needs surgery. But do that calculation. I'm sure you'll be disappointed. It's much less than you would like it to be. And now start pushing it up the way I described. And I think one day, maybe you'll be grateful for this tip. So thank you.
Could I just come in there, Prof? Thank you so much for that. So I've done that. I used to manage a practice in the NHS in UK, in Northwest London. And I did this about 12 years ago. We were struggling. So what I did, I pushed all my medical glaucoma, that's what we call them. We rag rated those patients. We pushed them out into the community base. We trained optometrists, nurses, and we had one ophthalmologist overseeing that group of patients. And then we kept the surgical ones in the hospital in the acute setting. It reduced our waiting list from like 1 year back to less than 6 weeks. And our conversion rate now is 98% to surgery. So yes, it works. Well done. Yeah, I totally agree. If we don't act on this, we will sink. Yeah. Thank you.
But remember, we can sink. The patients will go blind. That's the
Exactly.
issue. So good for you. I think you did it about a year before me.
Thank you very much. We need to move on to the next speaker. Thank you.
Thank you so much, Dr. Aitin Blumenthal. Next, we would like to go. Next, I'd like to introduce Dr. Maria Shaves. She'll be explaining us about excimer laser trabeculostomy.
Excimer laser trabeculostomy, commonly called EL, or combined with cataract surgery. The laser delivers up to 10 shots of 200 microns in the trabecular meshwork to connect the anterior chamber with the Schlemm's canal. One of the main differences with SLT are that in YELT the impacts are applied directly on the surface of the trabecular meshwork, and it uses a cold laser system that minimizes tissue fibrosis. YELT is combined mostly with cataract surgery. In this video, you can see that we start the procedure like with any other regular cataract surgery. After viscoelastic aspiration and corneal wound hydration with BSS, we inject acetylcholine in the anterior chamber, and after this, cohesive viscoelastic, to fill the whole anterior chamber, and especially the space between the iris and the cornea in the infranasal quadrant. That's the place where we will apply the laser. Now it's time to rotate patient's head towards their nose at about 35 degrees, and tilt the microscope. Before applying the laser, it's important to make sure that the anterior chamber is well pressurized and that we have good visualization of the angle with the gonioprism. This first surgery corresponds to a 66-year-old female with early open-angle glaucoma and intraocular pressure of 18 millimeters of mercury, on treatment with latanoprost and timolol. After delivering the shots, in most cases we observe slight bleeding in the anterior chamber due to the difference between the episcleral venous pressure and the intraocular pressure. This second case corresponds to a 74-year-old male with ocular hypertension. His intraocular pressure was 21 millimeters of mercury, on treatment with bimatoprost. After applying the laser, we will resume our normal position for cataract surgery, aspirate the remaining viscoelastic in the arterial chamber, and hydrate the corneal wounds with BSS. Twenty patients were included in the study. Most of them presented with ocular hypertension and early primary open-angle glaucoma. Most of the patients were on hypotensive medication before doing the procedure. The mean intraocular pressure before the surgery was 15.8 millimeters of mercury. After 6 months of follow-ups, this mean intraocular pressure was reduced to 13.7 millimeters of mercury. Also, the number of hypotensive medications were significantly reduced after 6 months. But are these results consistent over time? Previous studies have shown that similar results remain stable after 8 years follow-up. In conclusion, YELT seems to be a safe and easy procedure, which allows the reduction of intraocular pressure in patients with early glaucoma with low rate of complications.
Thank you so much, Dr. Mario. Next, I would like to introduce Dr. Hassan Khalid, who would be helping us understand preserved flow glaucoma surgery, clinical outcomes, and key learnings. So is not available right now. I would next like to introduce Dr. Gillard Litwin, who would help us understand development milestones with the e-shunt, the first retrobulbar draining GDD. Welcome you, sir.
Hello, thank you, and pleasure to be here. Let me just share my screen. Can you just show me where I can share? Oh, here I got it. Excuse me. No. So can you see my screen now?
Yes, sir.
Okay. So hello, everybody. Thank you for the invitation. A pleasure to be here. I'm Gilad Litvin, a physician, an ophthalmologist, and also involved in the past decade in developing various medical devices. My first patent that I drafted when I was in my fellowship was for this glaucoma drainage device. So we call it the e-shunt. The e-shunt has a few specifications that are different from current glaucoma drainage devices. First of all, we're trying to extend the safety of minimal of MIGS to the refractory and severe glaucoma space. We're doing that with a few strategies. First of all, the tube itself has some resistance, being of a lumen of about 125 microns and a length of 26 millimeters. The device itself gives about 3 to 4 millimeters of pressure drop from the inlet to the outlet. Therefore, immediately following the surgery, it can be open, patent, and start draining, reducing the pressure without the fear of having post-op hypotony. Another tactic in order to have this kind of safety is the fact that our drainage device drains the aqueous humor deep into the orbit, into the intraconal space. And when we look at studies from Graves' disease, for example, we can see that normal people have about 3 to 6 millimeter of mercury positive pressure in the orbit. And therefore, similar to the way we use CPAP, continuous positive airway pressure, to keep our lungs inflated when we intubate, for example, or when we ventilate, here we have an additional resistance to flow. Subconjunctival space has negative pressure. There are the veins that continuously drain the subconjunctival space, and therefore there we have no resistance, no additional resistance. Another thing that we do, we use a polymeric scaffold that's made with electrospinning of a non-degradable porous polymer that integrates with our Tenon's capsule, and therefore we will not need to use tissue to conceal the tube. The tube itself is also, it's not made from an aversive polymer. It's not from silicone or PHMB. It's from a specific aromatic polyurethane that's very inert and therefore does not create an inflammatory response. And lastly, this patch also has a small hoodie that conceals the entrance port. Therefore, it seals that place and does not have any leakage around the tube. We have a different kind of porosity, much less porous, but still does not create an additional resistance, a cap on the outlet This cap prolongs the patency of the device by delaying the fibrosis around the outlet, and therefore the slowly and gradual elevation of resistance to flow. You can see here on the corner our material technology. This is how it looks in scanning electron microscopy. We are continuously optimizing the material, and so far we have results that show the integration both in animals and in humans. We call it the Ever Matrix. The e-shunt itself targets, like I said, the severe glaucoma patients, severe and refractory, and it has a specific regulatory path with the FDA, the regulatory path of the aqueous shunts, which allows us to have initially a smaller clinical trial to be able to approve this and start testing it. The surgical approach is ab external, and the milestones that we have already reached, we completed a GLP rabbit animal trial. This is and all the biocompatibility. This is necessary in order to enter human implantations. We also did 3 compassionate implantations in blind, painful eyes, and I'll soon share the results. And we have an ongoing clinical trial in pets. When you do animal trials with rabbits, for example, all these rabbits are healthy young rabbits that do not have glaucoma, and their normal pressure is about 12, 13, 14 millimeters of mercury. So you have a very big challenge proving efficacy. But on the other hand, when you look at dogs and cats, which grow older and have glaucoma and currently have very few treatments, if you take pediatric Ahmed valves, which is currently what is used in the veterinary space, their lifespan is about 3 to 6 months, but by 6 months, all of them scar down and stop working. So we were able to apply for a clinical trial in a veterinary center and implant this in glaucomatous dogs and cats. Currently, we only have anecdotal data, so take that under consideration. You see here the 3 compassionate implantations that we performed in Tbilisi, Georgia. The surgeon was Nicolas Labaouri. He took 3 blind, painful eyes with pressures of around 50 on maximal tolerated medical therapy before enucleation. 2 of these eyes were bullous keratopathy as well because of the pressure. And instead of going the route of enucleation, he implanted the e-shunts in all 3 eyes you can see here. These pictures are 3 months post-op. We already have about a year and a half, but as they were compassionate implantations, we don't have the data. It's not a clinical trial, and we are not entitled to follow up longer. In 3 months, we can say, and also another thing that is different from our current configuration, the lumen was smaller. According to our calculation, we needed about 85 to 100 micron. And these tubes came out 85 microns lumen, and I'll share the results. So after 3 months, pressures were between 25 and 30. So they were draining, but not enough for a sighted individual. They stopped receiving treatment with drops, and the bullae all were absorbed. You can see the corneas are all transparent. The procedure itself was very simple to perform, less than half the time that it takes to perform a tube. After 20 minutes, the procedure was completed. And like I said, this maybe proves the safety, but we need to move on to a feasibility clinical trial, which is a formal clinical trial. A proof of concept first in human has a lot of names. We plan to do a single site, 10 to 15 patients with 1 year follow-up. Safety is our main concern, but of course, we're also looking to assess initially the feasibility. Once we have results showing that we're both safe and we do have short-term efficacy, we plan to apply for IDE with the FDA. The 510K I mentioned earlier requests 50 patients. We plan on doing about 70 patients and following them up to a year. We need to compare them to historic data, either Beervelt or Ahmed, whichever we choose as our predicate device. Regarding a few patients from our animal trial, the veterinary trial. You see here a 10-year-old mixed breed dog. She had lens instability. It's part of the specific breed, and therefore she elevated the pressure. The first eye, left eye, came with extreme pressure, NLP, and was enucleated, and the right eye, which wasn't stable on maximal tolerated medical therapy, underwent Eshan procedure. And you can see that throughout the follow-up, even 205 days post-op, the pressure is maintained at a good pressure without any treatment. And you can see the stability immediately post-op. The pressures are between 5 and 10, and eventually they stabilize at about high teens in these animals. Here's another patient. This is a cat, a very old cat. She also had one eye enucleated, and because of NLP and significant pressure and pain. And the right eye underwent E-shunt implantation. See, the pressure immediately post-op is 10, and eventually it passed away after almost a year, a little less than a year, about 9 months, from complications of hypertension. But you see that except for adding azopt about 2 weeks post-op, at the last follow-up visit, the pressures was maintained at 12 millimeters of mercury. So that's our plan. We're at 2025. We're looking for sites to initiate our first in human clinical trial. We plan on recruiting 10 to 15 patients and following them up for a year in order to prove to ourselves that we're both safe and efficacious. And once we have that data, we will plan to move on to multi-center clinical trial that aims at approving this device through the FDA 510(k) path. Thank you very much.
Thank you so much, sir. That was a very wonderful session. We'll be looking forward to looking at the human trials that would be done. Next, I'd like to introduce Dr. Anastasia, who would be helping us understand about TS Grid, which is designed for visual field. Welcome you, ma'am.
Hi, let me share my screen. Hello, I'm Anastasia Tsioga. I come from Greece. Thank you so much for your kind invitation. I will present the Tsioga Space Grid, which is designed for visual field examination. You all know what is visual field and the defects in glaucoma patients and neurological diseases. The gold standard is static automated perimetry, which uses bulky and expensive devices, but they are accurate and they give brilliant results with high sensitivity and specificity. But what happens when people don't have access to these devices, such as people with mobility disorders, remote islands, underserved areas, or even at the emergency department? There are many technology-free tests, such as confrontation visual field test, kinetic finger wiggle test, red desaturation test, the Amsler grid, and many other not commonly used tests. That's how the idea came, exactly 4 years ago, as you can see, to create a test that could help these people. Mentoring by Dr. George Spaeth, a person that is, for me, the high level in glaucoma. The first idea was to create a wallpaper. Unfortunately, this was really difficult to product, so the wallpaper went away, and 1 year later, the idea is to make a printable version with shapes. Not every individual could recognize these shapes, so after many attempts, shapes, colors, etc., we reached our final version, which I will explain in this presentation. The Tsioga Space Grid consists of 2 complementary charts, as you can see, 1 and 2, and the main chart. It covers approximately 43 degrees horizontally and 34 degrees vertically if you keep the test at 30 centimeters. As I told you before, it is printed in a simple printer. It's easy. In an A4 matte printing paper to avoid reflections. It consists of 102 squares, as you can see, with a narrow inside, with a contrast of 3.15 to 1 gray to white. As you can see, there is an empty space and an empty square with a narrow, an empty square with a narrow. This helps patient to understand which arrow you show to him. And as you can see, they double their size from the middle to periphery because we all know that the sensitivity is reduced toward periphery because of the reduced number of cones at the retina. Firstly, we cover the eye of the patient with whatever we have, an occluder, a patch, and we sit in front of the patient, keep that in mind, and we put the TS grid at a flat, rigid area like a desk at 30 centimeters. We advise the patient to wear the near vision glasses, and again, as I say, we sit in front of the patient and we put the test at a flat, rigid surface, as you can see here. Of course, we can do it with different ways, but it is important. Again, I repeat, we sit in front of the patient because we have to look his eyes, and we keep the test at a flat area. We advise the patient to look at the central spot and to try to see the arrows with the peripheral vision. And we start from the middle area because it's easier for them to perceive the arrows. And then we go to the periphery. And my advice here is to change areas at the periphery in order to maintain the central focus. When the patient sees the arrow, he tells us it looks up, down, or he points us to us. It looks left or right. If the answer is correct, we put a check or a circle. If it's wrong, we erase it with an X or a line. And I insist, we have to sit in front of the patient because this is the only way to see if he does the test correctly. As you can see, this patient move her eyes to the periphery, to the arrow that I point. This is wrong. We have to stop the examination. We have to repeat the instructions, like you have to look in the central dot and only with your peripheral vision, and we have to repeat the test. Maximum score is 102, pathological score is under 90, or if there is a pattern that reflects underlying disease. Two studies were conducted. I will refer only the results because of the lack of time. The first study was on neurological patients and was published at 2024 at Neurological Sciences. As you can see, it has high sensitivity and specificity and a good area under the curve. And when we did multivariate linear regression analysis, the TS score was highly statistically correlated with the VFI of Humphrey field analyzer. You can see that with the diagram also. And here is how the TS grid score reproduced left homonymous hemianopia, and here left superior quadranopia, and here a superior altitudinal defect. The second study is at glaucoma patients. It was published at 2025 at BMG Open Ophthalmology. Again, high sensitivity and specificity and a good area under the curve. In the multivariable linear regression analysis, we correlated TS grid score with VFI and MD of Humphrey field analyzer. And as you can see, the correlation is statistically significant, separately for controls and glaucoma patients. Here, the TS grid mirroring the Humphrey field analyzer, a glaucoma patient. So the TS grid, the Tsonga Spade grid, is a simple, low-cost, and easy-to-use test. Our studies showed high sensitivity and specificity. Of course, there are limitations. The most important limitation is that you cannot control the central focus of the patient. So you have to have that in mind, and many others, you can read them in our studies. Ongoing studies now, one there in India from Hema Talavar and Pradeep BV at Joshi Eye Institute, College of Optometry, Karnataka State, Humbly. Thank you, Hema. And the other one from Plutarchos Karidakis here in Greece at Yenimatas Hospital in neurological patients. Thank you so much for your attention. This is the site of the grid where everybody can download it for free. And my email, if anybody needs instruction or cooperation, I would love to. Thank you for your attention.
Thank you very much for a lovely and very informative talk. It was a pleasure to hear you and the way patient you explained. And I'm sure a lot of people globally who are watching you over 1700 will be interested to know more about it. So we now move on to our next speaker. And this one is a very interesting talk. And are you ready, Dr. Ruben? Dr. Ruben Belfort? Then we have Dr. Carl Goldnick.
So I think next, Dr. Steve will be joining us.
No, he'll be on the recording. So I think we'll ask Dr. Tandon to present first because she's come online. Dr. Tandon, please. Now, Dr. Tandon needs no introduction. She's the chief of RP Center at the Holland Institute of Medical Sciences, and she's going to speak on a very interesting topic. You see, because people who get into All India have natural intelligence, and she's talking on artificial. So let's go ahead, Dr. Tandon.
Hello, good evening. Good evening, Dr. Sethi, and thank you for giving me the opportunity to present. I just need a command to be able to share my screen. I'm not able to get that command. Oh, I've got it now. Yes, share screen. 1 second. Connected. Okay, extremely sorry. Firstly, greetings to everybody on the occasion of World Sight Day, and many congratulations to the team for having put such a wonderful program together to share all the innovations in ophthalmology. I'm going to share a little bit of an insight into our journey with AI and ophthalmology, and I've talked about it, or I've given it the title of augmented insight. So we all know that this is a buzzword and there's a lot of excitement all over the world, but the experience I'm sharing is a little different take on the subject, that in a big country like ours with a lot of remote areas, can digital health solutions and eye care help us in extending the range of our services to far-flung areas and hitherto underserved areas? And also, even in places where all the facilities are available, can it improve the patient flow and improve our efficiency in performing our functions as eye care providers? We all do know that global eye health is defined as the degree to which vision, ocular health, and function are maximized worldwide, thereby optimizing overall well-being and quality of life. And all ophthalmologists know very well that there are always limitations in how much effort we can put in and how far we can reach. So AIMS New Delhi, which is a public funded government hospital, multi-care tertiary hospital right in Delhi, and we have the RP Center, which is the APEC Institute for Ophthalmology for our country. We looked at this problem statement that to truly touch lives, can we understand the patient's journey through the healthcare system? And the idea was to see that how can we integrate the government services which are already available through the e-health platform, the expertise at AIMS, and also network with the peripheral communities to fortify the healthcare system with an AI-ready infrastructure. So largely, it was decided that there were 4 or 5 areas which really had a big public health need, and where the facilities and infrastructure were reasonably ready to be able to amalgamate and quickly provide some sort of a platform. So one was breast and oral CA, the other was diabetes, hypertension, and chronic respiratory disease. In terms of the ophthalmology, we felt that cataract and corneal opacity were very much required. And of course, diabetic retinopathy and glaucoma. So these were the diseases where we felt that it is important to work on AI applications. In addition, there were other disorders associated with growth and also chest x-rays and so on, radiology as well. Now, coming to AI and ophthalmology, we first explored what were the areas that we could work on. And of course, there are a large number that need to be worked on. But we also had to see that the engineering teams that we had and also the unmet need that was met, where were the gaps, and where could we quickly get good results in an area which is very difficult to handle. So given the large number of diabetics in our country, and also the fact that a lot of them are suffering from undetected diabetic retinopathy, and the fact that they all require regular screening, when we do not have adequate ophthalmic healthcare professionals in general and retinal specialists in particular. So the idea was that can we use AI models to provide a indication that the patients can be screened and safely said that okay, things are all right, you can stay as you are, and then we see you for the next visit, and the ones who we can identify or filter through that they require to seek help straight away. So AIMS Delhi is working as a center of excellence for artificial intelligence along with the Ministry of Health and Family Welfare to develop various AI solutions, with RP Center contributing a screening tool for diabetic retinopathy being in advanced stages of development and deployment. And I'm going to share that success story. So after the initial work that we put in and we were able to develop a tool, the task was to compare it with existing tools which are available. There is very famous Google platform and several other tools with the Remedio inbuilt with their handheld fundus camera. All these are available. So it was to see the tool that we had developed, how does it compare with these other gold standards? And the idea being that you have to see that we needed to have a device agnostic platform so that it could be used across disciplines and devices, and then had to be validated to be provided in a free sort of non-profit mode and free to use across the e-health services of the government. So this was then decided that we should test it out in our peripheral centers. We tested out in the vision center, and the engineering team needed to go there and see what is the flow of the patient so that they could come up with a viable model. So we used different models of training, then validation, and then testing. And the objective was to assess the diagnostic accuracy of the tool and also confirm what was its sensitivity and specificity. And the initial results were extremely encouraging, with a sensitivity of 90% and a specificity of 92% and an accuracy of 92%. As we develop the model further with greater number of images and improve the layers that we were able to put, the additional features that we added was the ability to grade for the diabetic retinopathy. We also included the vision component and also distinguished them into referable diabetic retinopathy and non-referable diabetic retinopathy. So we were able to have a report which says, yes, the person has diabetic retinopathy, but this can be monitored for follow-up, whereas a referable diabetic retinopathy would have to see an ophthalmologist straight away, and preferably a retinal surgeon. So there was near perfect agreement between the AI solution and the clinical gold standard, which was a retina specialist's opinion. Then we said that we have to assess the evaluation further in the periphery, and therefore after this initial, we were able to test it with our vision centers and in the community, and we were able to get a sensitivity of 100% and a specificity of 82% when we had different standards of grading and referral criteria. So when we looked at the different grades of retinopathy as well, we found that it had a very good predictive value with a kappa score of 0.76. So with that, we were able to develop a good workflow model for the e-health division. And then the idea was that is it user friendly? So we had initially worked on screening of 3,000 plus patients, out of which 1,400 plus patients did have diabetic retinopathy, out of which there were 1,000 plus referable patients, and and this was the average patients per day which were detected and subsequently sent to the higher center. The other additional thing we did is this is a little video demonstrating how the tool works. And the additional thing we realized was that you need to close the loop. It was not enough just to tell the patient that this is what you have and that you have to go ahead and reach the higher center, because sometimes the patient do not realize the importance, or they reach the higher center and they get lost and they end up with the wrong department. So therefore, we had to have a social worker in place to follow up, and also an SMS, repeated SMS going to the patient, giving a reminder. And we had to have at the center of referral also a receiving model, so that it could be confirmed that the patient had reached the right place and had been given the proper treatment. So and the image upload also is both. It can be directly online at the time of image capture, and in case there is some glitch, that such as an internet failure or some kind of a failure of the computer system, then it can be stored and it can be uploaded in a manual way subsequently. And this is how it goes, and this is how the report is submitted, and the final image, it even tells you that the image is clear or not. Is it adequate? And if not, then it prompts the optometrist to take another image. And sometimes the image may simply not be present, capturable, because of, say, corneal opacity or cataract. And in those cases, then the patients are referred anyway. And plus, we've also added the extra cutoff of 618 vision. Any person, irrespective of what the other findings are, if the vision are less than 6/18, they are also referred. So as you said, we looked at retrospective evaluation, then using high-end retinal images from the hospital, then a retrospective evaluation using retinal images from the open data set, and then a further retrospective evaluation using retinal images from the community ophthalmology low-cost fundus on a phone camera setting. And with all of this, the results were extremely encouraging. With that, we were armed with this information. I would like to acknowledge all the people who helped in this work. We have Vadhwani AI team, which is engaged by the e-health division of the Ministry of Health and Family Welfare, which was involved in developing all the engineering aspects of the model. And of course, we have the entire retina team at the RP Center and the community ophthalmology team, which helped to sort of develop it, give all the inputs, keep having repeated iterations of improvements, and then go ahead to have a model that is testable. And this has now come up with a very good a sort of a reliable model, for which we are going to apply. We have applied for CITESCO approval, and also we have government of Haryana and Rajasthan, and now even Maharashtra and Madhya Pradesh, who are looking at piloting this in their peripheral district hospital levels, where they're already well equipped with fundus cameras to consider using this approach. So with that, I'll stop here and like to share that we will also be working further with AI in other retinal diseases. And of course, we're working on picking up cataract and corneal opacity, for which we are going to go further off. So for diabetic retinopathy, the level of screening is going to be at the district hospital level. But for cataract and corneal opacity, we're going to go right up to the village level, that is the ASHA workers, who will be using their simple smartphone cameras to capture the devices and to capture the images and upload it to the system. Thank you very much for the opportunity to share our work.
Thank you for a very well explained system of how you're using AI. And I'm sure it'll go a long way in reaching out to the remote areas of the country. Are there any other questions from the panelists? With that, thank you very much, Dr. Radhika Tandon. It's been a pleasure hosting you, and we look forward to your visit to Arunodaya Deseret Eye Hospital in the near future. You'll be
Thank
happy
you
to
so
know.
much.
You'll be
Thank
happy
you.
to know we have more than 1,780 live audience going on at this time across all 10 halls.
That's really awesome. Thank you so much.
Thank you, ma'am. Wow.
Next, I'd like to introduce Dr. Carl Golnick. He'd be helping us understand the updates in optic neuritis. Over to you, sir.
Well, good morning from my standpoint. I'm on Pacific California time, so it's about 6:15 a.m. here, but good evening to you, and thank you so much for inviting me to take part in this really, I think, amazing meeting that you've arranged here with all the halls and speakers, much more than I thought we might see. So My task is short, but it's on changing paradigms in the diagnosis and treatment of optic neuritis. I will share my screen, and you should be able to see my first slide. I'm a professor of neuro-ophthalmology at the Barrow Neurological Institute in Arizona, United States. My objectives are that when we're done, you'll be able to describe several changes in the treatment of optic neuritis as compared to the optic neuritis treatment trial, ONTT recommendations. You'll be able to list some differentiating features of optic neuritis associated with MS, neuromyelitis optica, and myelin oligodendrocyte glycoprotein antibody disease. And hopefully also be able to list some systemic symptoms of MS, NMO, and MOGAD. So a lot of what we know about optic neuritis is from the optic neuritis treatment trial. We know that usually it is a unilateral optic neuropathy with some pain or discomfort around the eye in about 90%. There may or may not be optic disc swelling. Usually in typical optic neuritis and MS, it's mild swelling. And there may or may not be enhancement of the optic nerve as you see in the circled area on this MRI. Visual fields are always affected, but you can see any pattern. And all of these visual fields you're seeing here were seen in the optic neuritis treatment trial. So for me, the visual fields don't really help in the diagnosis. There is no specific pattern for optic neuritis. You can virtually see anything. And long story short, the ONTT was to look to see, are steroids better than nothing in the treatment of optic neuritis? And the answer was not really. There was no difference in the final visual recovery. The intravenous steroids only affected the rate of recovery, not the final vision. So for many years, we treated the patients in a certain way I'll describe in a moment. But you got to remember that the ONTT was done in North America. And that does not necessarily mean it applies anywhere else in the world. And even now in North America, I don't think the results apply. So the old treatment management was get an MRI, blood tests are not helpful. Use steroids if patients want more rapid recovery, but it will not help ultimate recovery. Steroids are not essential for vision recovery, and intravenous steroids were given for 3 to 5 days, often with no taper, just the IV steroids. So I want you to forget all this. This is no longer what I recommend in the treatment of optic neuritis. Ignore it, forget it. So what has changed? Well, a couple of big things have changed. So we've discovered tests for 2 new conditions, or at least 1 new condition. An old condition, Devick's disease, also known as neuromyelitis optica. In 2004, aquaporin 4 antibodies were discovered, and these can be obtained now commercially. I know they can in India and around the world. And then more recently, myelin oligodendrocyte glycoprotein antibodies have been detected, and these are now available in India and around the world. So neuromyelitis optica, the condition's been around for a long time, but we didn't have a test for it. And so it was kind of a self-fulfilling prophecy. When I was in training, you only thought about this condition if the person was blind and in a wheelchair. And now we know that's not the case. And I have plenty of patients with NMO who've just had 1 episode of optic neuritis and no systemic symptoms. But you can see, of course, unilateral or bilateral optic neuritis, cognitive impairment, seizures. Interestingly, you have this syndrome of where when it affects the posterior, a certain part of the brain stem where you have hiccups and nausea, vomiting. That can be presenting symptoms of NMO. And then, of course, wheelchair dependency can occur. And then MOGAD, myelin oligodendrocyte glycoprotein antibody disease, that's the last time I'm going to say that, the whole thing, is also a central nervous system disorder that affects the optic nerves and spinal cord. You need the MOGAD antibody to diagnose this, and it may be misdiagnosed as multiple sclerosis, depending on where you live in the world. But here's, I think, a very interesting chart from a recent review article from International in the Lancet Neurology, and you can see that in children, optic neuritis is the presenting sign or symptom of MOGAD, second most common in children. In adults, it's the most common. So ophthalmologists are going to see MOGAD. What are some of the characteristics? Well, there's more or less equal men and women, at least in this study from Mayo Clinic, a little more women than men. The median age is 31, but the range is 2 to 79, so quite the range. Disc swelling, unlike multiple sclerosis, disc swelling is present in the majority of patients, and very much unlike other forms of optic neuritis, more than a third of patients, it's bilateral and simultaneous. I don't think I've ever seen a patient with MS with bilateral simultaneous optic neuritis. And although the average nadir in vision is counting fingers, vision recovery to 2025 in most. So it's a generally not nearly as severe as NMO. What about the imaging? Well, in MS, typically there's a short segment of enhancement, as you can see in the upper right here. In NMO and MOG, it tends to be a longer segment. So if you see more than 8 mm segment of enhancement, you should really be thinking about NMO or MOG. Keeping in mind that not every patient with optic neuritis has enhancement of their nerve, and radiologists will often reply, no enhancement, no optic neuritis. That is not true. And I've had patients with hand motion vision in both eyes from MOGAD with absolutely no optic nerve enhancement. And in MOG, which can help differentiate it from other forms of optic neuritis, you can see not only enhancement of the central nerve, but of the optic nerve sheath, so-called perineuritis. So perineural enhancement, if you see that, then you should really be thinking about MOGAD. So this is just a busy chart from another review article, and I tried to point out and highlight some of the things that differentiate. So steroid dependence. MS and NMO are really not steroid dependent. MOG can be steroid dependent. I've seen patients who were treated with 5 days of intravenous steroids getting better in the hospital, then they're discharged not on steroids, and they see me 2 weeks later and their vision is getting worse. So you have to do a prolonged steroid taper in MOGAD. The risk of blindness is very high in NMO, 1 episode, and you can be legally blind forever. The diencephalic symptoms, those are the hiccuping and nausea and vomiting, and then the perineural enhancement that I mentioned. Regarding treatment, fortunately, the treatment initially is the same. So for NMO, it's high-dose intravenous steroids or high-dose oral steroids, the equivalent. Now that's in the United States, we have 50 mg pills, 50 mg pills of prednisone. That's 25 of those pills a day, which many people use instead of intravenous. It's a lot cheaper in the US to give them pills. If there's no improvement, or if there's rapid improvement, ultimately they're going to be treated chronically in NMO because it's such a bad actor. If there's no improvement in NMO on the steroids, on the intravenous steroids, we treat them with plasma exchange. So this is a big change in the paradigm, the treatment paradigm. And there are a bunch of biologics now that have been approved, at least in the United States, to use long-term. Fortunately as well, MOGAD is treated the same way initially. And also you can use the oral equivalent, but unlike NMO, if there's a single attack in full recovery, you can observe these patients. There's some debate about this, whereas if they have recurrent attacks, then you're going to consider chronic immunotherapy. And of course, those biologics, which are very expensive, have been approved as well. So what's the approach to optic neuritis in 2024? Well, you still get the MRI with and without gadolinium. Never order an MRI of the brain without gadolinium. We get MOG and NMO antibodies. Depending on where you live in the world, you might look for syphilis, tuberculosis, sarcoidosis, Lyme disease. We're going to treat with high-dose steroids now, waiting for these blood test results to come back and consider plasma exchange or intravenous immunoglobulin. Sometimes there's been some debate about whether we should even just start this right away in things like NMO. And then oral prednisone taper pending the blood test results, because if it's MOGAD, you want to continue the oral steroids for at least probably a couple months. So in summary, advances in neuroimmunology have changed our approach to optic neuritis. We must check NMO and MOG antibodies because treatment and prognosis are different. And I thank you for your attention and congratulate you on your meeting. I look forward to listening to some more of the talks.
Thank you very much, Dr. Carl. I have a quick question. How would you differentiate retrobulbar neuritis cases from some of the new versions of the optic neuritis A, and B, what would be the difference in the treatment?
Yeah, there is no different in treatment. So whether the person has retrobulbar optic neuritis or optic neuritis with disc swelling, the treatment is going to be, the initial treatment is going to be the same. And although NMO and MOG can cause a retrobulbar optic neuritis. As I showed with the MOG, the majority, sort of maybe even the vast majority of patients have disc swelling. But I think the bottom line is whether they've got retrobulbar optic neuritis or optic neuritis with disc swelling makes no difference in your treatment or your diagnostic approach.
You said was that you don't take the visual fields very seriously now in optic neuritis. So do you routinely do them for your patients with optic neuritis?
Yeah.
Because it's
So
an expensive investigation in India.
Yeah, so the answer is I don't do the fields to make a diagnosis. I do the fields for a test to follow for improvement because we're hoping, of course, that all of these patients improve. So in the US, probably people are going to get a visual field so that when I see the patient, I say, we're going to get a field. We're going to see you in 6 weeks or 8 weeks, and we're going to repeat it. And I'm hopefully going to show you how much better you are. But from a diagnostic standpoint, do you really need it? I don't think you really need it. I mean, all the other signs of optic neuritis should be there, symptoms and so on. And so I don't think you need it to make a diagnosis.
Have you ever had the occasion to see a patient of retrobulbar neuritis in one eye and optic neuritis in the other eye at the same time?
Yeah, it's a good question. The answer is I don't think so. I think whenever I've seen bilateral
We had
optic
one
neuritis,
patient.
have you?
Visit.
Yeah,
We had one.
it's either been, both have nerves, both nerves swollen or both nerves not swollen. But I'm trying to think if I've ever seen somebody with bilateral simultaneous retrobulbar optic neuritis, and I'm not sure that I have. I've definitely seen the bilateral disc swelling optic neuritis simultaneously, but I don't know that I've seen bilateral retrobulbar optic neuritis simultaneously.
Thank you very much for giving us your precious time, and we hope to have you at our next webinar next year this time on the World Sight Day.
Okay.
Are you
Looking
coming?
forward to it.
Your pleasure. Next week. Thank you.
Okay, bye-bye.
Dr. Hina, you are mute.
Next, I'd like to introduce Dr. Gabrielle Di Salvo. She'll be explaining about a roller coaster ride. Sit back and fasten your seatbelt.
Hello. Good evening, everyone. It's a pleasure and an honor to be here. Thank you so much for inviting me. Let me share my screen. Should be this one. Can you see that?
Yes, ma'am.
Yes, ma'am, you are able.
No. Wait a second. I don't know what's happening here. Can you see the presentation?
No, ma'am.
Dr. Hina, in the meantime, can you get the next speaker also to check the slides?
Sure, sir.
What about now?
Yes, ma'am, now it's visible. You can
You
start the
can.
slide.
So yes, so let me move the camera because it's got the second screen. I got two screens with me. Okay, sorry for the inconvenience. So, okay, is it now on presentation mode or not?
Apologize to disturb you, ma'am. Ma'am, click on display setting. In the
Where
left
is
top
it?
corner, ma'am, click on display setting because your slide is coming in next slide mode, ma'am.
Okay, let me stop sharing.
No,
Let me
go
try. Yeah, no, let me
go to
just
share
try
screen and
to.
double click on first option, ma'am.
Let me just try to share, to do it this way. I'm sharing the screen number one. Let me just try again. So we go here, screen one.
Yeah, ma'am. Go to the slideshow mode,
Is it
ma'am.
now okay?
Yes, ma'am. Fine, ma'am.
Yes.
Perfect. Perfect. I managed. So it's shifting between the two screens. I'm sorry for this inconvenience. Very good. So yes, this is an interesting
Before
case
you
that
start, I just want
yeah.
to let you know that none of us is having a seat belt on our chairs.
Okay. It's a safe one. It's a safe one. Okay. So yeah. This is a 17-year-old male whose past medical history include hypertension, hypercholesterolemia. He had an acute myocardial infarction in the past, taking clopidogrel, and the current diagnosis is of multiple myeloma with IgA kappa. He had a bone marrow transplant back in 2017 and currently is on palliative radiotherapy. His family history is negative and he presented to this unit with a bilateral posterior vitreous detachment, diagnosis of advanced dry age-related macular degeneration, and he presented with an epithelial membrane in the left eye and a lamellar hole. His main complaint was of blur vision, and the optician referred him back to exclude neovascular AMD. His vision was slightly down on the left eye, being 624, and his anterior segment and intraocular pressures were normal. So in 2023, though, despite these findings, he was referred to have a vitreoretinal colleagues, and it's by looking at the autofluorescence, you can certainly see the salt and pepper autofluorescence and beyond the vascular arcade and patches of geographic atrophy being hypoautofluorescence. So why was this patient referred to the VR clinic? What are we missing? So when we check the other multimodality imaging, which is multicolor modality, you can notice that whilst in the right eye, which is on your left side, you can see these hyper reflectance related to the area of geographic atrophy. On the left eye, there are a few rounded lesions which are isoreflective. And you can see, in fact, I don't know if you can see my mouse moving with the arrow, you can see, in fact, that they have an hyporeflectant border, but also they are isoreflectant. So you can see the blood vessel underneath them. You can see the blood vessels very clearly under any of these little rounded lesions. So the first thing that comes in your view, once you do an OCT, is that the patient has obviously a lamellar hole, which was previously diagnosed, and an epiretinal membrane. And then there is also some amount of tractional edema. But if you look in the vitreous cavity, there is actually a rounded hyperreflective rounded lesion, which inside is hyperreflective. The patient had further scans moving forward, and you can see how this shows the OCT, moving the OCT scan backward and forward. You can see an unusual wavy presentation of the epiretinal membrane, creating a kind of roller coaster effect. In fact, as some of these bubbles, I would say, they look like suspended in the vitreous, some others seems to be originating from the epiretinal membrane and forming this kind of omega sign, 1 and 2, for instance. So there are multiple loops actually originating from the epiretinal membrane. The patient never had any previous surgery. So if you were thinking that those fluctuating air lesions were actually silicone oil bubbles or perfluorocarbon bubbles, you're wrong. The patient never had any vitrectomy. So the patient was then referred to the MR clinic. What did we do? Well, we performed a fundus fluorescein angiogram to see whether the fundus fluorescein angiogram might give us any more information. Now, whilst the one on the right is showing very clearly the geographic atrophy and the cuticular drusen and the stars in the sky appearance, the fundus fluorescein on the left eye is out of focus because the photographer, the ophthalmic imaging photographer, was trying to focus on these lesions. And you can see that once again, they are transparent, they are isofluorescent. And to prove that the patient didn't have previous vitrectomy, we also checked the far periphery with an optos, and there were no scars from other vitrectomies, from the ports, basically. We therefore know that one view is never one view. And what we notice is that sometimes we forget to look at the 3D features that our scans allow us to have. Therefore, I will invite you to always check your three-dimensional scan, and you will see that whilst the scan is moving and passing through, you can see that whilst those lesions seems to be floating into the vitreous, they're actually not. Each of those bubbles is indeed attached to the epithelial membrane and is convoluting up and down. And they look like they were floating into the vitreous because whilst the scan was moving in one direction, was actually catching the next lesion. This is a rendering of the images done by Professor Peter Malocca from Basel, Switzerland. And not only, so this is the video starting again. Let me go forward. So not only you're able to see the three-dimensional structure of the lesion, you can see the lamellar hole at the macula, but you can visualize like there are many channels inside these structures, and some of them are also going one on top of the other, creating almost like a snowman appearance. The channels are of unknown origin, but you can clearly see them while the scan is moving up and down, and you can see how they seem once again with this kind of omega sign originating from the epiretinal membrane, which is appearing quite wavy. So I'm not sure whether you ever seen anything like this because we haven't. What did we do with the patient? The main complaint was blurred vision. Therefore, we decided to do a cataract surgery in the left eye. The vision remained stable. And in the last June review, compared to before, the cataract showed that there was still some movement within this structure, this hyperreflective complex. And in fact, there are more lesions appearing on the same cut of the spectralis. And the lamellar hole after the cataract surgery seems to be closed. So as we never seen anything similar, we were trying to understand what the etiology could be. So paraneoplastic, because remember the patient has an IgA kappa myeloma, idiopathic versus acquired cyst, possibly to be a precystic stage of a free-floating primary vitreous cyst, or maybe genetic. And because of that, we decided to do a complete retinal disorder panel, including collagen type 4, and all of these tests came back negative. So the myeloma usually gives us complication in the retina hyperviscosity, retinal microaneurysm, vein occlusion, and Purkinje retinopathy. This kind of complication was never reported before. Also, in this patient, the changes are appearing only in one eye, and this kind of phenotype has never been reported. What if it's a primary vitreous cyst? These are either congenital or acquired. Their dimensions are very variable between 0.15 and 12 millimeters, and the incidence varies between 5 and 68 years of age. There is only one report in the literature which has shown that they are made of a hyperreflective wall with numerous hyperreflective membranes, creating, even in this case, a multilobar configuration of the lumen. So this is very similar to what we saw, with the difference that in our case, only one of those lesions was freely floating in the vitreous. And regarding the call for A1G mutation, our patient was negative, and this is autofluorescence of another patient of mine, which presented with isolated tortuosity of the retinal vasculature. In our patient, he was negative and for this particular gene, and he also had no systemic association. What are we left with? We're left with a convoluted epiretinal membrane of unknown cause, which presented with some structural similarity to a primary vitreous cyst, maybe might represent a precystic stage. It's negative to genetic testing, and the patient blurred vision remains his main complaint. We were debating whether to do a diagnostic vitrectomy, and I would be grateful for any of your further thoughts. The patient at the moment has refused the vitrectomy, and therefore we are just studying the natural outcome of the disease and progression of the disease. We publish a video of this roller coaster, let's call it, and you can find it on JAMA Ophthalmology. We also got accepted just 2 days ago, again, a video but with the three-dimensional rendering, which hopefully will be published soon. And we presented the case at the recent Euretina in Paris. So I would like to thank you once again, and I'm open for questions or even better, answers. Thank you.
Thank you for a very illuminating and a very interesting talk, because very rarely do you get these kind of presentations. Are there any questions from the rest of the panel? So you now need to come to India and talk on this at the All India Ophthalmic Society to have a wider base.
It would be an honor to be there.
So which
And
city are you
finding an
in?
answer. We are in England, in Southampton, the University of
So
Southampton.
now we have direct flights from London and other cities. So in Delhi awaits your arrival.
Very good, very good. Thank you once again for the kind invitation and the opportunity.
Next speaker, please.
Next, I'd like to introduce Dr. Aishwarya Sriram. She'll be talking about management of visual snow syndrome. Welcome you, ma'am.
Hi, good evening to you in India. Thank you for inviting me to speak on the management of visual snow syndrome. Let me share my screen. One second. Okay. All right. So as you kindly introduced, I'm Dr. Aishwarya Sriram. I'm with the University of South Florida, Tampa General Hospital, and I look forward to speaking with you about the current management of visual snow syndrome. I don't have any relevant financial disclosures. I'll start by talking a bit about the background of visual snow, then the treatment options, and any future possibilities we might be able to anticipate. So first off, what is visual snow syndrome? It's actually a constellation of syndromes where the primary syndrome, the hallmark syndrome, is visual snow. And that visual snow itself is a persistent positive visual phenomenon that patients often describe as seeing snow in their vision or grainy, pixelated vision. It might look like static. It might look like flickering dots. It might look like a TV screen, for example. It's usually throughout their visual field, and it's usually binocular. In rare cases, it can be monocular or asymmetric. And this is just an illustration drawn by a patient of what the experience is like. So as you can see, they can see the objects they can see the objects, but in front of the objects is kind of a grainy, pixelated experience that makes the visual experience not so pleasant. The visual snow is usually constant. It's present for often months or years, and it's usually stable throughout a patient's life. But when they first notice the visual snow, they may report an increased progression, and that's thought to be generally from increased awareness of the symptom. It is a benign condition that doesn't usually affect visual functioning, but of course it can be disabling, and that's why patients come to our office complaining of this symptom. Visual snow syndrome as a syndrome can also include other symptoms, and that is palinopsia, like seeing after images, various entoptic phenomena. Patients also might report photophobia or nyctalopia, and of these, the palinopsia and the entoptic phenomena are going to be the more commonly reported. And the actual criteria for visual snow syndrome is the visual snow symptom, as I mentioned, that should be in the entire visual field and lasting more than 3 months. And they should have at least 2 of the other four symptoms that I mentioned, the palinopsia, entoptic phenomenon, photophobia, and nyctalopia. In addition, the patient's symptoms should not be consistent with a migraine visual aura, and they should not be better explained by any other kind of disorder. We can think of visual snow syndrome in two groups, the primary form, which is going to be idiopathic, and the secondary form, which can be due to numerous causes like trauma, drug use, other ophthalmic conditions like retinitis pigmentosa, or neurologic conditions like stroke. And for the purposes of today's talk, we'll be discussing the primary or idiopathic form. So primary visual snow syndrome can affect both children and adults, but the median age is around 30 years old. It can affect both men and women and is thought to be present in roughly 2% of the population. It's thought to be due to impaired sensory processing. That includes both a mix of subcortical network malfunctioning as well as cortical hyperexcitation. Patients with visual snow syndrome tend to have comorbidities that can include migraines. In fact, 60% of patients have comorbid migraines, either with or without an aura. They can also have tinnitus, dizziness, or a variety of psychological issues like anxiety or depression. It's important to note that the etiology of visual snow syndrome is thought to be organic and not psychogenic that might have previously been thought to be the case. And that's due to the stereotypical symptoms that patients endorse and the physiologic data, such as patients having reduced contrast perception, impaired adaptation of their visual evoked potentials, and higher antipsychotic error rates. So because of all of these things, it's thought to be an organic phenomenon. And as you can see here, one study had shown that patients with visual snow syndrome even have hypermetabolism of the right lingual gyrus and the left anterior cerebellum. So again, thought to be organic and not psychological. So in order to diagnose visual snow syndrome, we want to make sure we take a thorough history and do a full ophthalmic exam, which could include visual field and OCT, as well as a full neurologic exam. And you may also want to consider an MRI or an ERG to, again, rule out those secondary causes, the neurologic and the ophthalmic causes. Okay, so moving on to the treatment options. It's important to note that for your patients with visual snow syndrome, one size does not fit all. Generally, though, the first thing you want to try as the ophthalmologist is going to be counseling your patient. It's thought to be the most effective, and so again, it should be tried first. When you counsel your patients, it's important to address their emotional response, acknowledge that it can be affecting them emotionally, the way they perceive things, as well as acknowledge that it is physiologic, so that it gives their perception of the world some physiologic credibility. You also want to reassure the patients that it's unlikely to affect their vision and it's unlikely to progress, and let them know that it can vary in presentation. And of course, that the condition is not fully understood. All of these things can help provide reassurance for our patients. You can try to emphasize to your patients that patients with visual snow syndrome just see the world a little differently. And it's important for them to try to look through the visual snow rather than focusing on it. That can help them cope with the disability that they might perceive from visual snow. Another option is going to be lifestyle modifications. So to start with this, you could consider a symptom diary for your patients. And once you have acknowledged their aggravating factors, for example, it's important to advise them to try to avoid those. And that could include caffeine or other stimulants, alcohol or hallucinogenic drugs. Often artificial or harsh lighting can be an aggravating factor, and excessive screen time. It's also important to advise the patients to have to improve sleep hygiene as well as diet and anything they can do to reduce any stress or anxiety, such as through exercise or meditation. Therapy is another option for patients with visual snow syndrome, and forms of therapy that have been previously tried and studied include cognitive behavioral therapy and mindfulness-based cognitive therapy. It can help reduce the patient's symptoms, the overall disease burden, and address any comorbid psychological issues they may have, like anxiety or depression. In this study by Wong and colleagues, they put their patients through mindfulness cognitive therapy. And as you can see on the left side, patients did report an improvement in the symptom severity as the weeks went on. And they also reported an improvement in the impact that the symptoms had on their visual functioning. So both were positively affected by this mindfulness-based cognitive therapy. Treating the comorbidities is another aspect of visual snow syndrome treatment to keep in mind, whether that's having the patients referred to for psychological therapy, making sure they have treatment for migraines if that's another comorbid condition, and addressing the tinnitus. Even though these conditions might not directly affect the visual snow and treating them might not directly improve the visual snow, it can help improve the patient's overall quality of life, which is our goal when they do have visual snow. Hued glasses are another option that have been studied. Studies have shown that patients prefer blue or yellow filters and have reported some improvement in their visual functioning, up to 80% when using these glasses. There have also been reports of improvement in the photophobia that the patients might experience and the palinopsia as well. Even the anxiety, which was studied with the GAD-2 questionnaire, there was found to be an improvement in patients' anxiety by using filtered lenses. So that is something else to consider. People might be wondering about medication options for those with visual snow syndrome, and truly no medication has been found to really improve or worsen visual snow. There haven't been any randomized clinical trials studying this, and so the results are really mixed, and there isn't one direct medication option for these patients. It's really something just to consider when the patient's symptoms are intolerable, you've tried everything else, and nothing has worked. Some suggest that starting with lamotrigine can be helpful, up to a dose of 200 milligrams twice a day. Of course, if the patients don't have any improvement, or if they experience any side effects, it's a good idea to discontinue, although it has been helpful in less than 20% of patients. But of course, there can be worsening, there can be allergic reactions, and it's definitely not the first thing to do. Acetazolamide has also been used by some, starting with 250 milligrams twice a day and increasing to 1,000 milligrams in divided doses. But again, if there's no improvement or the patients are experiencing side effects, it should be discontinued. Other medications that some encourage include antidepressants or benzodiazepines. These, of course, may also help address any comorbid psychological issues like anxiety. Anti-epileptics have also been tried, as well as various other medications like propranolol and baclofen. But of course, there haven't been any concrete results to support the use of these medications. So my advice for that is really to think about the risks and the benefits thoroughly and beware of any side effects. Definitely would not recommend jumping to a medication. Visual rehabilitation is also something that is endorsed for visual snow syndrome. This could be ocular motor therapy that can treat oculomotor issues like convergence insufficiency or balance issues. And some people suggest that there is a reduction in the palinopsia that the patients experience. For example, one study by Sang and colleagues looked at 21 patients with visual snow syndrome that underwent 12 sessions of neuro rehabilitation, and they did find that it improved certain aspects of their functioning, like ocular motor functioning, and they also found that their visual functioning questionnaire score improved. So the patients reported improvement in quality of life. They endorsed improvement in various activities like their mental health, their social functioning, etc. But the study didn't look at the actual improvement in the visual snow symptom. So that is just something to keep in mind. So what can we expect with future treatments for visual snow syndrome? Visual noise adaptation is something that's being studied, where patients have to view high contrast dynamic noise patterns, something that basically looks like visual snow, looks like the TV static. And some have reported that after viewing this, they've had less visual snow, sometimes to the point of invisibility. And the longer the patients are exposed, the more the improvement is. Transcranial magnetic stimulation is another treatment that we might see in the future. The research is still ongoing. It's where electrical currents are aimed at altering neuronal firing. But again, at the moment, we don't have any concrete evidence for this. In summary, I would say that for your patients with visual snow, one size does not fit all. You might need to try multiple approaches, of course, with counseling and reassurance being the first and foremost. And additional research is definitely needed. So we'll see how the condition and the management develops over time. Thank you all for your attention, and thank you again for inviting me.
Thank you very much for a lovely presentation. This is one topic which is very rarely covered in such detail. What is palinopsia, ma'am?
So it's when a patient will look at an image and then after looking away, they'll still see the outline of the image, like a trailing image.
Something like an after image.
Yes, exactly.
So I request Professor Yetik to give a few comments about this presentation.
Sir, you are muted.
So we request Professor Yetik to give us a short introduction of his study.
Excuse me.
Dr. Sri, how many patients in a year would you be seeing of this condition?
Me personally, probably less than 50.
You know why I'm saying it? Because I think we miss the diagnosis many times in India because we don't go through the details to that extent.
I feel usually the diagnosis it's often straightforward because the patients come in saying, I'm experiencing this, and they've usually even researched it already. So they say, could this be visual snow syndrome? They've searched online, why is there static in my vision and things like that.
Are you coming for the American Academy to Orlando?
Yes.
We look forward to seeing you there. We have a poster there on the community work midline.
Oh, great. Looking forward to meeting you in person again.
Dr. Hina, the next presentation, please.
Over to you, Dr. Monish.
Good evening, everyone. Thank you so much, ma'am, for your great PPT and then presentation. We did have a lot of information about it. Now, I would like Dr. Hussein Yetik to come around with the topic of pseudo-retinalization. Sir, over to you, sir. We'll be waiting for your lectures right now.
Okay, thank you very much. I would like to begin by thanking Dr. Sethi family for this invitation, for kind invitation for this very important and valuable meeting. And the title is Pseudo-Retinalization of Vitreous. And I want to start my presentation by this striking photo of a 7-year-old boy whom I treated by intravitreal bevacizumab monotherapy. And it's easily seen that there are membranes regressed, and there's a membrane at the top of the optic nerve, and the macula seems very well, and huge areas of PAR, peripheral avascular retina. And if what we have been told for the pathogenesis of ROP so far were true, we wouldn't found so fine photo after a serious intravitreal bevacizumab treatment after such a case. But so what did those pathogenesis told us? We know there are two pathogenesis, and in the beginning they have the different mechanism of action for the mechanism of the vasculogenesis stopping, but thereafter they converge and do the same final pathway and define the ROP as ischemic retina and VEGF release and neovascularization. And ultimately, those two pathogenesis suggest that ROP is a generalized retinal disorder, and it's a hypoxia-related ischemic neovascular disorder, and that's why there is a need. They suggest a panavascular retinal ablation. But if they are true, there are some questions needs to be answered. First, about the demarcation line. First, why does it develop? I mean, in comparison to other ischemic neovascular disorders, such as PDR. There is demarcation line in PDR, but we don't see it by ophthalmoscopy. It can be seen by fluorescein angiography. And why there is a white line at that epiretinal plane, and why it can be seen by ophthalmoscopy. And still, we can see second and third in the age of anti-VEGF treatment. We do inject and all demarcation disappear, and after a while we see another demarcation. If the pathogenesis were true, depending upon the intrauterine and extrauterine conditions, the demarcation was developing depending upon those pathogenesis theory was caused by the intrauterine and extrauterine conditions. But after injections, we do see second, third, and even more demarcation line. And why the disease always stays in the same line, stage 1, stage 2, stage 3, why it stays in the same line? And while regressing, why do we see crossing vessels? And why do we see plus disease? How the plus disease can be explained? And regarding the response claim to be neovascularization, if it is a neovascularization, why it is limited to the demarcation line only? Why don't we see metastatic neovascularization such as NVD, NVI, NVE, and why they are as the continuation of the normal vessels? This surgery I recorded was almost 20 years. If you can see, you see the vessels are in continuation with the normal vessels, and even we can cut off it like this, you see. I cut it off in the vitreous. It's something like continuation of the normal retinal vessels. And for rubeus rubeus is this recanalization of the pupillary membrane. It suddenly disappear after sclerotomies, and real neovascularization can never disappear in seconds, you know. And why the disease persists if we don't perform laser near to it? You may perform almost whole avascular retina, but it may stay in the area where the laser spots don't touch. So, and regarding the differences in the treatment techniques and rationales, and we do treat the disease by extrapolating from the other disease. We perform panavascular, they suggest a panavascular treatment for ROP, but by the years, I asked a question, depending upon those questions, whether ROP is a generalized retinal disorder or localized disorder. So I performed a limited laser treatment on the demarcation line, and as you can see, only laser treatment of the demarcation line can regress the disorder. And depending upon those conventional hypotheses, it was told us that if we perform laser for avascular retina, then the vascularization would stop and the vascularization wouldn't advance periphery. But you can see by this OCT angiography, even after laser, vascularization go toward periphery on the laser area as well. And there's a study I published and I presented in Euretina 15 years ago. And last August, a new study, almost as the same as my study and referring me, confirmed that limited laser treatment is able to treat the ROP disorder. And after anti-VEGF injection for other ischemic disorders, we never can expect, for example, we may even 100 times of injection, we can never expect for revascularization of avascular retina in PDR. But we can expect it in ROP. And you can see years after, this case is 11 years, and no laser treatment for the periphery, and it's still almost perfect. So then what is the real pathogenesis? My pathogenesis hypothesis was reported in this book, and my hypothesis, pseudo-retinalization hypothesis, depend upon the immaturity of ILM, immaturity of vitreoretinal interface. From a fertilized egg to mature, all maturation process is differentiation and demarcation from left to right. From left to right, as we mature, we get more demarcated, and in the vitreoretinal interface, more going to right, we get PVD, more left, we get ROP. What's the meaning of this? I define the hypothesis as from the optic nerve to the periphery. Normal retinal vasculature goes by via ILM or guided by ILM because of the immaturity of the ILM, the ambiguity of the vitreoretinal interface. At the time, they stopped to separate, distinguish where is retina and where is vitreous. The vasculature stops there because they cannot distinguish where is retina and where is vitreous. And ILM stays and accumulated in the area of vitreoretinal interface, and we see this picture as demarcation line. And as the disease progresses, it's transformed into stage 2. And of course, still new vessels, still vasculogenesis is produced, and they accumulate behind and like ready to explode like a bomb. Then after a breaking point, the vessels deviates into the vitreous instead of lining on the retinal plane, and they oriented into the vitreous cavity, and the normal vascular network of retina starts to be developed in the vitreous cavity. And after a while, even after injection, the ILM progress and demarcate the true vitreoretinal interface, and then we can see they separated. At this animation, I showed my pseudo-retinalization. They start to go in the vitreoretinal interface. If they cannot separate the vitreoretinal interface, ILM accumulates there, and thereafter the normal vasculature deviates into the vitreous. But when ILM matures, they do a cleavage to the pathological vascularization, and thereafter it continues to grow toward periphery. And this mechanism can explain second or third demarcation after injection. And you can see at this video of OCT angiography that may show. And vessels going into the vitreous cavity, they are the ghost vessels. And it's the same as my pseudo-retinalization hypothesis. So ROP is not a neovascular, stage 3 is not a neovascularization, it's an aberrant vascular network that deviates into the retinal plane. It's which I defined as pseudo-retinalization of the vitreous. And ROP is not a generalized disorder of the retina. It is not an ischemic neovascular disorder of retina. And it is not related with the hyperoxy or hypoxy. It is not an analog of PDR. And avascularity of ROP is not an analog of dropout avascularity that we see in other ischemic disorder. And ROP is a unique disorder and resembles only to itself. And it cannot be managed by extrapolating from other retinal disorders. I tried to summarize. I think hopefully it's okay for this.
So, Professor Yetik, in the case of ROP, the treatment that you give with these patients, is it given while they're admitted in the nursery, while they're in the hospital, or do you give them with an outpatient procedure?
I do same in hospital as well as outpatient in private clinics. Do the same, both together.
Thank you very much for a very illuminating talk. And are you going to be there at the American Academy this year?
I couldn't, excuse me.
Thank you very much for a very nice presentation. And we look forward to hosting you in India for the All India Ophthalmic Society meeting in March next year, if you'd like to come to Jaipur.
Sure, it will be my pleasure. It will be my pleasure. Thank you very much. It's very kind of you.
Dr. Hina, please, and Dr. Manish, please go ahead with the next speaker.
Next, I'd like to introduce Dr. Rubens Belfort, who would be helping us understand about Oncophone telemedicine project.
Hello, guys. Thank you for having me. Hello, Dr. Sethi.
It's a pleasure hosting you, Rubens, and you've been coming to India so regularly. Ruben has a son like in Lucknow in India, so he travels very often. He and his father run an excellent clinic. We were recently their guests in Brazil, and we hope to have him soon in our hospital in Delhi. Go ahead, Ruben.
Thank you. Let's see if I can share my presentation with you guys. It's a great pleasure to be here. And we're going to hopefully tell you a little bit about ocular oncology and the Oncophone. So when we talk about eye cancer, we have a number of different tumors that can affect the eye, right? Carcinomas, like in this picture, melanomas, like in the little video you see here. And the problem with these cancers is that it's very rare. So the residents know a lot about it, but when we go to the real world, we tend to see very few of this. This is a ocular adnexal lymphoma, VHL with a tumor of the retina. And this is a case of metastatic disease from the lung to the eyes. And this is what we see very often in Brazil. It's good that you don't see this very often in India due to racial profile. You see more retinoblastoma than melanomas. This is a primary melanoma of the eye. And this is a case of a retinoblastoma in a center we work with in Angola, in Africa. So a number of different tumors. And then how often do a general ophthalmologist see a melanoma? So in India, with your huge population, Dr. Sethi will see a melanoma every 13 years. So it's very rare to keep up to date. He will see 100 cataracts in a day, but a melanoma every 13 years. And in Brazil, every 20 years. So the question is, how can you keep all ophthalmologists up to date with a very serious disease that can kill your patient, but you will only see a patient in Brazil every 20 years? So we would get these very advanced diseases, like this little girl from the Amazon forest, and you can see the left eye with a huge retinoblastoma, very bad prognosis, or these huge carcinomas we would hope never to encounter. Why? Because the patient didn't look for an ophthalmologist, and maybe the eye doctor that saw this patient was not trained or didn't remember how to treat this patient. So how are we approaching this problem? We have a YouTube channel, Instagram account, and the famous Oncophone. The idea is to provide free consultation services to every ophthalmologist in Brazil. We don't reply to patients. We only reply to ophthalmologists. If they find a case they think it's eye cancer, you can see here very informal. We get 4 or 5 consultations a day, depending on the time of the year, and we try to help them establish the diagnosis and try to help them to treat the very early cases before they get very advanced disease. So it's a very basic video, something I know we can also do in India. You can see the doctor with a 20 diopter lens plus a phone can check the back of the eye, send this image to us, and we can say this is a congenital hypertrophy of the RPE. It's not a melanoma. It will never become a melanoma. Done. And we just helped both the doctor and the patient. So we did a review of the cases, and we got 1,055 consultations in the past years. And you can see most conjunctiva, but half of the cases we got from kids with suspected tumors were retinoblastoma. So only looking at those, that small fraction of 4% of the cases we got, 2% of the total cases were retinoblastoma and were referred to a tertiary center to be treated. So we help establish the diagnosis. If it's a more complex case, let's say retinoblastoma or a metastatic disease to the eye, we refer to the oncologist, but the basic cases in the beginning can be treated by the general ophthalmologist, cure the patient, and prevent advanced disease. Of course, this empowers local ophthalmologists, reduces advanced cases at referral centers, facilitates diagnosis and treatment, probably reduces the burden and the suffering of these patients. We know it's not an ideal solution. Every patient should have an experienced ocular oncologist, but in huge countries like Brazil, India, and so many countries in Asia, having a system like this works very well, very low cost, and helps so many patients. So all the doctors in Brazil have this. It's a very informal system. They send a message through WhatsApp, and we help establish the diagnosis. These are a few pictures I hold very dear. As you can see, ocular oncology doesn't pay very well. This is me on a side job in New Delhi, making some money. And on the Hanuman temple, मैं Brazilian हूँ, फिर भी दिल है Hindustani. And this is my beautiful son that lives in Lucknow. And I had the pleasure to take Dr. Professor Rum Singh and Anna back to Taj Mahal after almost 30 years. So thank you so much for having me, Professor Sethi. It's an honor to be here. Hope to see you soon. Thank you so much.
I wanted to ask you a question, Ruben. That is, when you have these patients come into your clinic, especially the ones from the Amazon and other places, how do you manage to do the therapy, the various chemo and radiotherapy, the cost involved and the continuity of the treatment? How do you manage that?
So we have universal healthcare in Brazil. So when we get the patient at an early stage, they're entitled to have free service from the government. Of course, it's not perfect, right? It takes time. And when we get very advanced disease, there is very little we can do. But if you find a patient in an early stage, our hospital here in São Paulo, even for retinoblastoma, we have intraarterial chemotherapy and we have plaque therapy, and it works very well. The huge problem, Professor Sethi, is when we get the advanced cases, and then we have very little to offer to these patients.
We look forward to hosting you soon. And we now move on to the next speaker, Dr. Heath.
Thank you. Bye-bye.
Thank you so much, Dr. Rubens. Next, I'd like to introduce Dr. Hassan Khalid, who would be helping us about preserved flow glaucoma surgery, clinical outcomes, and key learnings. Over to you, sir.
Okay. Okay, thank you. It's my pleasure to be with you. Thank you, Dr. Sita. Thank you, Dr. Hina, for inviting me. I was confused if it is the correct hall or not. Okay, let me share my presentation. I'm trying to share the screen, but cannot appear in front of me. So Windows.
So you can share your screen by just clicking on the share option, then select screen share.
Yeah, I go to share screen.
Yes, sir. Then go to the screen you want to share, the window you want to share.
Is it clear now?
No, sir, it's not visible right now.
Share screen.
Then tap on the window you want to share.
So there is a Chrome tab. After pressing the share screen, there is a Chrome tab window
Yes,
and
sir.
entire screen. I go to window. Okay,
Okay, sir.
okay, now I think.
Now on the bottom right corner, you can see the share screen option. Then you have to click that.
I can't see it.
Will Dr. Himanshu join?
No, it's not sharing, unfortunately.
While you work on the computer, you can check it out with the technical team. They'll help you. We can have the next speaker present, and then the doctor can come back on this.
Hello.
Yeah.
Yeah, Dr. Hassan, sir. Sir, click on share button at the bottom side, a green color button. Then double click on first option, sir. That is screen or desktop.
Yeah, I'm trying. There is share screen. I click it. Now there is a Chrome tab window and entire screen.
Yeah, click on entire screen. Click on
Yes,
entire screen.
yeah, I press now sharing. Do you see something? Anything now?
Now click on entire screen. Double click on entire screen or click on entire screen and click on share.
Okay.
Sir, when you will click on share, then
This
click
one.
on yeah.
Yeah, this is double click on the entire screen. Now
Sir,
I go
under
to.
the sir, under the entire screen, there are a option of the screen. When you will click on that, that would be go blue. So double click on that. Yeah, click on that and click on share.
Yeah, now.
No. When you are doing, sir, what is going on?
No, sorry, it's not working. I don't know why.
Dr.
Now,
Ariel, are you walking?
Sir, click on share button. A window will pop up.
yeah,
On that
this is
window,
this. Yeah,
there are many options like entire screen, application window under the screen. So under the entire screen, the option is coming, window is coming, screen. So double click on that.
it's not working, unfortunately.
So do you have a Mac?
No, yeah, I'm working on the Mac. Yes. So now I press share screen. Now the screen in front of me choose what to share with appzoom.us. The site will be able to see the contents of your screen. There are Chrome, tab, window, and entire screen. Okay?
Yeah, click on entire screen.
Yeah, entire screen. There is only screen that we are watching now. So then
Yeah.
share, then pressing share. Okay.
Okay.
And this is my presentation. Is it clear?
No. We are not able to see your screen. When you will click on share, so I think that you have not given the permission to Zoom to share screen on Mac.
No, it's not.
Dr. Hina ma'am, do you have the presentation of Dr. Hassan sir?
No, I don't have it. So would it be possible if you can mail it to me and I would try sharing it from my end?
Yes.
Let's get the next
Dr.
speaker
Hassan?
going and we can work it out with the technical team. I'm sure we can manage it. There's no problem. Dr. Khalid, you'll be the next speaker. Who is the next
Yeah.
speaker now?
Meanwhile, Dr. Khalid sir, please mail the presentation or WhatsApp the presentation to Dr. Hina. And after that presentation, your presentation will come. Okay?
Okay. Okay. Thank you.
The next speaker is Dr. Ariel Nata Yakub and Dr. Hina, please introduce.
Yes, sir. Next there would be Dr. Juliet Willer, who would be talking to us about patient perspective on acanthamoeba keratitis.
Dr.
Just a
Juliet
second.
joined.
No, I'll have to share his screen. Is not present. Just a second.
Dr. Hina, please all the other speakers also do get
Good
ready.
afternoon. I want to thank Dr. Aaron Sethi for inviting me to speak at this important webinar on Site Day. My name is Juliet Villa Sinclair-Spence. I am the founder and president of the Acanthamoeba keratitis Eye Foundation. I'm here not just as a founder, but as someone who has lived through AK. Global annual incidence 2.3 to 2.9 eyes per million people. Please, let me begin by sharing my journey in a short video. We went in 2016 to Italy, to Tuscany, and we stayed in a rental house, and they had a swimming pool. I went in, I opened my eyes under the water. So when I came out of the water, whoa, I didn't lose my contact lens. But the following day, my eyes started complaining. After 2 days, pain was not going away. The doctor that attended me said, oh, you wear a contact lens, you have a bacterial infection, and gave me some medication drops. The pain was so excruciating that I went on emergency again to the doctor. So they sent me to Amsterdam to get a confocal scanner. So he confirmed I had AK, and from that day I had to drop non-stop every hour for 4 days. And I went on survival mode. When I went in the hospital, they turned the lights off of the waiting room because they could see I couldn't even handle the light. You want to take your eye, you want to put a fork and pull it out. And she said, tomorrow you get an emergency cornea transplant. For me, going outside was a nightmare. After 6 months, we took the patch out, and the surprise was that I did not have to do another transplant. Acanthamoeba keratitis exists. It might be rare, but numbers are increasing, and we need to do something about it. AK changed everything. Even 8 years later, I live with nerve pain, light sensitivity, reduced vision, PTSD, depression, and a deep fear for water near my eyes. I'm no longer the person I was. AK changed my life forever, and yet I still call myself lucky compared to others. Now let's talk about the patient perspective. How do we experience and what it truly feels like to live with AK? These are the eyes of patients who we refer to as AK warriors, a small but powerful glimpse of what AK looks like. AK doesn't only affect the eye, it affects the body and mind. 80% misdiagnosed, 48% herpes simplex virus treated with steroids worsen the outcome. Patient feels like guinea pigs, trial and error approach to care. The pain is severe, trigeminal nerve pain is involved. Extreme light sensitivity makes even the simple tasks impossible. The psychological impact is huge. The constant fear of losing sight or even the eye itself. And even after treatment, many face lasting complications. Living with AK is not just a diagnosis, it's a daily battle that reshapes every part of a patient's life. How does AK really feel? To truly understand AK, we need to hear the voices of those living it. Here are some quotes from AK warriors. The pain is off the scale. I want to pull my eye out. AK blinds, AK cripples, every light hurts. My life is put on hold. Treatment feels like acid on my eye. I feel alone, misunderstood. Everyone thinks I'm exaggerating. I live in a dark room, not by choice, but because of AK. AK doesn't end when the infection clears. The complications, aftermath, and struggles can last for years, even for a lifetime. Current reality when we talk about patient journey. Infection begins, AK is not in the radar, 80% misdiagnosed, 40% as herpes. Treated with steroids worsen the condition. Treatment fails, maybe it's AK. No standard therapy, no pain management, no support. Depending on the country, inpatient or outpatient, outcome, slow recovery, ongoing complications. What it should be. AK is recognized early, accurate diagnose, standardized treatment begins, pain management with nerve modulators, psychological and peer support is provided, care option to decide together with the patient, with a better recovery and life is restored in the best it can. About the foundation. It was founded in 2022 and is the first patient-led global nonprofit organization focused exclusively on AK. Our mission is to support AK warriors, bring the patient perspective to healthcare professionals, help prevent AK through educating contact lens users, raising awareness about this rare and devastating disease. We proudly offer support groups with over 1,500 members, a global ambassador network, an active social media presence, an online hub with resources for patients and professionals. We are a member of Eurodis and recognized by Orphanet. And last but not least, we have an expert medical advisory board. You can't diagnose what you don't think of. AK must be on your radar. Always consider AK in contact lens users and or cornea injury with water exposure. Please avoid steroids until AK is ruled out. Thank you for listening. I appreciate your time and attention today. If you have any questions, I'm happy to answer them. Let's keep raising awareness together.
Thank you very much. That is a very nice pre-recorded message. Very informative. We now move on to the next speaker. Dr. Hina, please.
Hello. Next, I'd like to introduce Dr. Steve Arshinoff, who would be telling us about intracameral moxifloxacin dosage, administration, and potential toxicity.
I would like to thank the SETIs for inviting me to take part in Pan Ophthalmologica 2025 and to apologize that I cannot do this live as I'm at another meeting, and so I'm submitting a recording of my presentation. I'm going to speak to you about intracameral moxifloxacin, its dose, administration, potential toxicity, and some new things we found out about it. My disclosures are on the slide. My real disclosure is that I was the first in the world to use intracameral Vigamox, and clearly I like it. I think I have a responsibility to update the world on how it's doing and how we should use it, and I like bilateral cataract surgery. So the Americans were quite proud of their decreased incidence of postoperative endophthalmitis when they published this article, and they showed that between 2000 and 2022, they managed to decrease the infected rate from 1 in 500 to 1 in 2000. That's not bad unless you try to look at what the best in the world is. In Laval, in Quebec City, they began to adopt bilateral cataract surgery about 10 years ago, and they now do all of their cases as IS-BCS, and they have shown, using my method of bilateral cataract surgery and intracameral Vigamox, that their infection rate is less than 1 in 14,500. This is very similar to the infection rate that the International Society of Bilateral Cataract Surgeons reported 10 years ago of 1 in 17,000. It was Lieber and Matthews in 2017 who published an article illustrating the efficacy of the drugs we use intracamerally. They found that only moxifloxacin was effective in killing all of the pathogens they found in isolates from Bascom Palmer Eye Institute endophthalmitis cases, and that you had to use more than 0.5 milligrams into the eye to be effective against all of the pathogens. If we look at the different drugs that have been used intracamerally, we see that vancomycin, which was popular previously, no longer is as a consequence of hemorrhagic occlusive retinal vasculitis. Cefuroxime, which is very popular in Europe, has been quite good, but there has been reported instances of allergy, TAS, and macular edema. But the big problem is that it doesn't kill enterococcus, and cases with infections of enterococcus are not common, but they often cause blindness in the patients. Moxifloxacin, on the other hand, has the most broad spectrum efficacy and has the least allergy and complications. It's now the most commonly used prophylactic antibiotic globally, and the corneal toxicity has been shown to be 1,250 micrograms per mil for 24 hours, which is much, much higher than what we inject into the eye. Alternatively, there is a syndrome of Bate or Batty, which has been reported, which is a reflection of the toxicity of this drug and the class of drugs to pigmented tissues. This was highlighted by the case of Leighton Falconberry in March of 2016, where after a vitrectomy, they trapped moxifloxacin behind the iris and got translumination of the iris in glaucoma. If we look at the toxicity of moxifloxacin to pigmented cells, we realize that fluoroquinolines cause phototoxic reactions as one of their main side effects, especially when exposed to UV light. Lomifloxacin and sparfloxacin are the worst. Ciprofloxacin and norfloxacin come next, and moxifloxacin is among the least melanotoxic of the fluoroquinolones. This is due to a methoxyl group that it has at position 8 of the quinolone system, and it confers photostability and reduced toxicity. The EC50 is the dose at which half of the melanocytes will lose viability if that concentration is sustained for 24 hours or more, and that turns out to be 0.25 millimolar for moxifloxacin. If we look at how toxic that turns out to be in the eye, moxifloxacin has been shown to be safe to RPE cells in concentrations of 15 micrograms per mil for 24 hours. We can produce a graph where we show the abatement line in the black here of moxifloxacin in the anterior chamber relative to the horizontal red line, which is a toxicity level which, if sustained for 24 hours, will be toxic to melanocytes. The other horizontal lines, the bottom one is the target dose we need for the MIC of the usual target bacteria in endophthalmitis. This is the MPC, the mutant prevention concentration. And then these two lines, the two highest blue lines, are the MICs of the most resistant strains ever found in endophthalmitis cases in ophthalmology. So we see that the dilute moxifloxacin, 150 micrograms in 0.1 mil, the abatement line is only above the toxic line for 12 hours and then falls below it. So it's nowhere near a 24-hour sustained level of a toxic dose for pigmented cells. Whereas on the top red line over here, we can see that if we inject 500 micrograms in 0.1 mil undiluted moxifloxacin under the iris and let it get trapped, we have an abatement line which we don't really know very well, but we know there have been cases reported with phakic lenses and in the cases of Falconberry where the drug gets trapped and we get damage to the iris. So what happens? Well, in October of 22, the ASCRS reported an advisory for all American doctors talking about the ways to administer moxifloxacin safely. They accepted the dose of Liebman Matthews, but they recommended using one of the two systems. They were proposed either undiluted from the bottle or the method used in California. They did not discuss the preparation that I had been talking about for a number of years, so we thought we should compare them. So we did a study looking at the three methods: one, undiluted from the Vigamox or Sandoz bottle; two, method of Shorstein at Kaiser; and three, our method of a higher concentration that we publicized before. And what happens is, if you inject the antibiotic into the eye, as we inject into this closed space of the anterior chamber, of course, there's a leakage of an equal amount, and you can calculate how much actually stays in the eye. So we did this, and you can ignore the mathematics because nobody likes mathematics. And you see we get these three lines. The blue line is the line for the direct from the bottle injection. And the reason that line is very steep is because it's very difficult to get it right to this horizontal line, the black line, which is the target dose. So that tells you that if you give too much, it's easy to give a higher dose, which could be toxic, or you could give too little. So nurses often know that and tend to give the doctor a lower amount, and it tends to be injected in large enough doses. The method of Kaiser only asymptotically ever approaches the dose we need to achieve in the eye, which means we always inject too little, whereas the dose that we propose tends to go and become parallel to the target dose, and so we tend to usually get the correct amount in the eye at the end of surgery. The conclusion of that paper we published was to inject 150 micrograms in 0.1 mil, 0.55 mils, this being the most effective and safest method we were aware of to use moxifloxacin. But that too has problems, and the problem was that the Arvin 2 million eye study, published a few years ago, showed that when a PCR was present, or we put a secondary lens in, the infection rates were 10 times higher, and whether the patient got intracameral moxifloxacin or not, they still had a much higher infection rate. So we thought we should look at a way to get around this. So first we thought, well, why not increase the concentration of moxifloxacin to 250 micrograms in 0.1 mil? And we drew this red line showing where that would happen and the dose we need for PCR cases in the light blue, and the darker blue line showing the dose we need for regular cases. So the green line is the 150 micrograms per 0.1 mil, and the red line is 250. What we find out is we indeed can inject less for a higher concentration. But when we raise the concentration, we run the risk again of trapping it behind the iris and maybe having toxicity to melanocytes. Also, because we have two different amounts, we run the risk of having to have two syringes in the operating room, one for regular cases, a low enough dose to avoid toxicity, and one for post-PCR cases. So we thought that was impractical, and we thought we should look at the whole thing again. And here's what we found. On the left-hand side here, you see the first graph, which shows what I just told you before. And on the right-hand side, we see these three lines. And what these three lines are the amount of moxifloxacin that remains in the anterior chamber on the vertical axis, and on the horizontal x-axis is how much you inject. So the green line here is when the anterior chamber is the expected 0.5 mils after a routine cataract surgery. The orange line is 0.7 mils, which is the volume of the space you're trying to make sterile from getting an infection when you break the capsule but don't lose vitreous. And the gray line is the volume of the anterior chamber when you break the capsule and lose vitreous. And you can see what happens here is that when you go from one line up to the next, you get a higher amount of moxifloxacin retained in the eye by injecting the same amount, and it's retained because when the volume of the space into which we inject the moxifloxacin is greater, more stays in the eye. And then we thought, well, we could inject between 0.7 and 0.75 mils, and we don't get a high enough dose in regular cases to be toxic because it stays below 600 microns. But what happens is when we have a larger space, having broken the capsule, more stays in the eye, and so it becomes more effective for cases that have PCR. So our conclusion is we should probably stay with the 150 micrograms in 0.1 mil and then just inject a little bit more. The left-hand video here shows how you should not inject undiluted intracameral moxifloxacin. First, they lose some putting it in, and then they lose the rest in trying to adjust the intraocular pressure. On the right-hand video, first the main incision is sealed, and the chamber deepens when it is sealed. You then come back with the intracameral moxifloxacin, and as you inject it, you see the chamber will deepen, and which allows you to rotate the lens if you want to the proper axis, and you inject enough so that you exchange the entire anterior chamber. So in summary and conclusions, intracameral moxifloxacin is now the most effective and most popular intracameral antibacterial prophylaxis globally. Undiluted moxifloxacin from the bottle is not safe when trapped behind the iris in phakic eyes. A proposed concentration of dilute moxifloxacin, 150 micrograms in 0.1 mil times 0.55 mils, is the best for routine cases. And the same thing can be used in a larger volume for post-PCR cases, and it's effective. The amount remaining in the anterior chamber increases with available space, and so I now inject 0.7 mils routinely because it is not toxic and is good for all cases. A commercial preparation is now becoming available in Canada, made by Labtician, and I think we can go ahead and we can drop POE rates to less than 1 in 20,000. The final point is that this dilution effect only occurs with dilute moxifloxacin, and you would not get increased retention of the drug if you use it straight from the bottle. So that's why we use dilute moxifloxacin. I want to thank Bill Shee and Brendan Tao for helping with this presentation, and I thank you very much for your attention. It's a great pleasure to be here with the SETIs for this meeting once again.
Thank you very much, Steve, and we wish you a safe travel to Egypt. We now request that the next speaker, please.
Over to you, Dr. Monish.
Good evening, everyone. I'm very privileged to introduce the next speaker, that is Dr. Amar Issa sir. He's currently working as a CEO and co-founder of Iris Eye and Laser Center Iraq, and he has many titles and publications on his name. His topic would be corneal allergenic intrastromal ring segments. Over to you, sir. Thank you, sir.
Thank you very much. Good morning, good afternoon, good evening for everybody. I'll share my screen if
Technical team, please help.
Is it okay now?
Yes, sir.
Yes,
Yes, sir,
we
it's
can
okay.
see your presentation, sir. Sir,
Okay.
move 1 or 2 slides, please, sir.
Okay.
Yeah, it is moving also, sir. Yeah.
Okay. Very good.
Go to first slide and go on, sir.
Thank you very much for Dr. Anna for inviting me to present during this very nice international webinar. I want today to present something about a revolution in keratoconus management. Getting from a patient of keratoconus from a state of like this picture of topography to like this one, it deserves a lot of attention. Okay, this cannot be easily achieved with current methods of conventional treatments. We know the impact of keratoconus is widely on the globe, especially in our areas of Middle Eastern countries. And this is usually affecting the younger people. That's why it affects a big chunk of the working class of people, the active people. The disease progression is highly variable, but still most of the patients in our localities, because of the allergy and the predisposing factors, they get into disease progression, which is usually not under control in many cases. This all will impact the economy in terms of direct expenses and indirect expenses of loss of the power and the visual impairment, and affecting at the end the quality of life of those patients. So what are the options currently available to treat those patients? Of course, glasses remain one of the mainstays of improving the vision in such patients, but most of the time these glasses are not effective to get the better quality of vision they deserve. Again, the contact lenses remains one of the mainstays of treatment, but despite the presence of wide availability of types of contact lenses, usually many patients, especially in hot weather and the climate, they do not tolerate these contact lenses. What comes into effect is the intracorneal rings, the PMMA rings. These, they were available now for the last probably 20, 25 years, and still they are one of the mainstays of improving the corneas of keratoconus patients, but yet they have a lot of drawbacks. We will come to later to those things. On the other hand remains the corneal graft. Corneal graft is one of the things which are time tested for patients with keratoconus. In between these modalities of treatment, tissue addition is gaining momentum in terms of treatment of many of those patients not tolerating contact lenses, getting drawbacks from intracorneal rings, and yet not deserving to go to corneal grafts in avoidance for complications. So what are the types? Of course, there are a lot of types of tissue addition in keratoconus, but I'll just concentrate on the corneal allogenic intrastromal ring segments, what is known as CARES. This procedure was invented by Dr. Susan Jacob as a safe and effective treatment for keratoconus. At the same time, it can be individualized. Many patients, they differ. Their right eye differ from their left eye. And this, of course, goes to every patient in keratoconus. The material is usually biocompatible because we are taking corneas, okay? So we don't run into the risk of, some biocompatibility issues. At the same time, it's reversible and adjustable. What I'm using now is the Kira Natural because of the paucity of the corneal grafts and the scarcity of the material and the preparation issues. What comes from Kira Natural is the recut segments or rings, which can be used for implantation during case procedures. This procedure proves also to be safe. In our series of patients, we have a very high safety index. And efficacy index is also very high. It's more than 1.5. The learning curve is relatively straightforward and very short, especially for people who learned before how to use the PMMA rings. The material is sterile and acellular, so the risk of rejection and the need for steroids and suppression is very minimal. How these segments compare to keratoplasty? Of course, in terms of safety, these are very safe. In terms of biocompatibility, very rare to have a rejection, especially with the acellular and sterilized material. It can be individualized. We said reversible and adjustable, not like in keratoplasty. We are still short away of getting, the perfect outcome for most of the patients. Learning curve, despite being very long in keratoplasty, here it will be very short in CARES. And the complication rate, very important that we know that the complication rate in keratoplasty with the best hands is still very high compared to what the experienced people get with the CARES and even novice people really. So how is the surgical procedure is done? Usually, if you have a femtosecond laser, whether, whatever the Intralaser, the Visiomax, the Zimmer types, all of them, any laser who can create tunnel in the cornea is very effective in this type of a treatment, and really it shortens the treatment time and makes the centration of the segments very well. Usually I use settings with the Visiomax 800. I use a setting of about 4.5 to 7.5 millimeter tunnel width. The depth, most of the cases, is around 250. Some of the cases in which, for example, we did repeat implantation of CARES after removal or explantation of a PMMA rings, we get into a little bit less than this depth. Usually we do two opposing incisions, around 1.5 to 1.75 millimeter. You see here in the video, the creation of the tunnel is very quick. It takes about 6 seconds only. You just need to open the beginning of the tunnel and the incision, and then you start inserting these segments. Usually these segments are really flexible to some extent. That's why you have to use some sequential pushing of the segments inside the tunnel, or you can dehydrate. I do not use the dehydrated sort of things because usually it needs a lot of time, for the segment to dehydrate, and then you risk the loss of some effect of the dehydrated segments. So how we plan these care segments? Usually the planning of these care segments is relatively straightforward. Once you adopt a nomogram, which is the Alfonso nomogram for classification of keratoconus and the staging. Usually this type of, I found this type of nomogram very effective and very easy to comprehend how to support and distribute the steepening of these rings along these cones, along the axis of the steepest meridians. So depends, of course, on the shape of the keratoconus, on the asymmetry of the keratoconus, on the refraction, of course, is taken into account. And then there is something called the Istanbul nomogram. This nomogram is mainly for location of the care segment. It can be manipulated to some extent. I don't believe that sometimes, because the nomogram states that you start from 4 millimeter to 7 millimeter. I usually do not like getting into the optical zone very much, so I put 4.5 millimeter to 7.5 millimeter. So it can be manipulated to the best interest of the patient and the experience of the surgeon. So in most of the cases, you get very good results. But the most impressive and important results, usually you get it in type 1 or type 2 of Alfonso classification of keratoconus. So I'll give you some real cases. This is a 20 years old male. Post-operatively, he got a vision of 6/12, despite having counting finger vision before the surgery. You see here that the cone occupies more than like 40 or 50% of the cornea and is very eccentric. It responded very well, and then the difference map is, if you can look at the right hand of the image, you see that the difference map approaches -15 diopter, -16 diopter probably in some places. So regularization of the cornea, especially initially, you get impressive flattening. Despite this, of course, we have some stabilization of effect at 3 months. Usually we lose some of the effect, despite the presence of very low K reading. Now you see the K readings here are around 37, 35, but usually it improves over time. And this is a pattern of the CARES implant and the epithelial thickness profile changes after these cases. Another case, the vision was anchor rectus, counting finger 4 meter before the surgery. And then after the surgery, with regularization of the cornea and improvement from a sort of very high irregular astigmatism to some sort of regular astigmatism happened in this case. And again, the flattening approaches 12 to 13 diopter. The vision improved to 612 really in this case. This is another case of a vision of 624 with high myopic astigmatism. Post-operatively, most of the myopia disappeared and the astigmatism improved to very much to a very good vision, improving the vision to 612 in these cases. So again, this is also the same thing. You will see a lot of cases. Most of the cases will improve very dramatically with this type of procedure. So the nice thing with about CARES is the customization. Once you start doing few cases, then you realize that for many patients, you can customize the implant itself, the segment, into a shorter one, into probably a thinner one on one side, into splitted segments. Sometimes you put, you can fold the segments on itself to get more of a thickness. And then in this way, you can manipulate the cone itself to have a better regular shape. In this case, for example, with a partial thickness implant, you get a vision of 6/9 with only one segment of CARES, and then you get these nice results. Sometimes we put two segments with the CARES because especially with the type 5, I think, the bow tie type of Alfonso classification, usually you need two things to flatten the whole cornea, two segments. And this is also, again, is doable. Again, this is another case also, you can put two segments where you can use accessory part. Sometimes you have the cone concentrated on one side, but still you have some asymmetry on the other side, not very high. So you need some small segments to put there to flatten that area as well. So cutting some part of the CARES implant, instead of throwing it away, then you can put it in the tunnel in the opposite meridian. So you get very good results also with these manipulations. Sometimes we run into overcorrections because the idea of the CARES that we put the thickness available to improve the vision to the best, to flatten the cornea as much as possible. But sometimes we run into overcorrections, and these overcorrections get persistent, as in this case. This is a female patient. She had a prior cross-linking 3 years ago, and she had high stigmatism, and the vision was 624. When we implanted the segment, there was excessive flattening, what resulted in high mixed astigmatism. The cylinder increased, and the difference vector was very high compared to what we initially needed. So what we did, we adjusted the segment, we removed part of it, okay, we cut it into half, and then we replaced the segment again. Then we got into a vision which is slightly better and much less reduced flattening of the cornea. Any risk for CARES? Of course, no surgery is without risk. Very important to explain to the patient that this is not a refractive correction. This is a therapeutic option for the patient with keratoconus. And this is, we have to stress this several times for the patient, because most of the patients, they think when there is a new procedure, it means that this procedure is for correcting vision. But in reality, this is a therapeutic procedure, and we are not very sure about, how much it corrects the myopia, how much it corrects the astigmatism, and whether we need more adjustments or not. So this is, I have to stress, especially for novice people, for people, younger people who are starting to do the surgery. It's very simple, very effective, but yet no promise for the patient, please. Role of cross-linking. We are not sure about the role of cross-linking in such cases. Many of these cases will remain stable. We don't have much experience with this type of surgery, probably a few years, but many patients will remain stable. Some of the patients will start to have re-steepening of their cones and reappearance of the irregular astigmatism post. That's the reason why we do a regular follow-up. Usually, I follow up patients 1 month after the procedure with an MS-39 topography or any corneal topography, of course. and then we follow up the patient after 3 months, then after 6 months, then after 1 year. And in this course, we just start to compare what happens with the cornea during this time. Usually, we said initially we get overcorrections. Then later on, after 1 month or 2 months, we start to lose some of the effect, but then it stabilizes at 3 months. So between 3 months and 6 months, if we get more losing or more loss of the effect of the care segment, then we advise for cross-linking. Now, many people do not advise about combined cross-linking at the same time because of the risk of corneal melting. Most of the, or there are some reports of corneal melting at the same time when doing simultaneous cross-linking and cares. Infection remains one of the risks, of course, in any type of surgery. We had one case only, probably out of like 50 cases, one case of very early pseudomonas keratitis complicated by viral keratitis, but was treated well, and he responded to treatment and everything was fine. Rejection remains one of the issues, although we don't have a reported case of rejection because these segments are sterile. Extrusion of the implant, again, there are some reported cases of extrusion. That's why we do not advise having tunnels which are very narrow, just because of these narrow tunnels usually will cause a pressure necrosis sometimes, and then extrusion of the segments out of the tunnel and removal. Yet, of course, it's very easy to remove these segments. So in summary, CARES opens a wide door for keratoconus management. Relatively easy to plan and perform. And definitely it decreases the need for keratoplasty. And I know the future holds promise for this type of procedure because there will be much more customization, much more, provision from the eye banks for these segments. Because at the end of the day, we are not wasting the corneal tissue as a whole. You get used for part of the tissue for some patients who are eager, to have these procedures to improve their vision. Thank you very much.
Thank you for an excellent presentation. I have a question for you, doctor. That is that have you tried these rings on patients who've undergone C3R and still progressing to keratoconus?
You mean doing this for cases of prior cross-linking?
Yes,
Patients had, yes. I had many of these patients. I have probably 6 or 7 patients who had already cross-linking done either 6 months ago, 1 year ago, 3 years ago. I have a patient. All of them, I did not see any in terms of technical things. It's just the same thing. There is no issue of cutting through these corneas, implanting these segments into the cornea. I did not face any difficulty. At the same time, I did not see any planning difference or results difference in terms of whether the cornea is more rigid or less. All of these corneas, they behave in the same way. Once you put any tissue inside the cornea, it gets a lot of flattening, and this flattening, I think, it just offers the same benefit whether the patient had cross-linking before or not, because many patients who had cross-linking still they suffer a lot. Cross-linking is not an ideal procedure in terms of visual outcome for the patients. It's not like, for example, you do rings, you do ICL, you do keratoplasty, usually patients improve. But in cross-linking, usually most of the patients will have, in addition to, yes, they stabilize, but really there is not much improvement, and there is some persistent suffering because of this non-improvement. And most of those patients really benefit from having this type of procedure.
So, thank you very much for a very nice presentation. I'll now request Dr. Monesh to please invite Pradeep Grewal presentation.
Good evening, everyone. Mr. Pradeep Agarwal is going to talk about the capacity challenges within the medical retina service. Over to you, sir.
Madam Pradeep Grewal is a lady, and she's from the National Health Service in England. And Pradeep, are you live? Good. I can see you've changed your dress now.
No, it's the same dress.
So welcome aboard, and we have crossed to 2,200 audience globally across
That's
all streaming platforms.
amazing.
All thanks
Amazing.
to a faculty like you and Dr. Mukesh Patel and others. So go ahead with your
Yeah,
presentation.
there's a
We're
lot
eagerly
of
looking
familiar
forward.
faces.
And I can see that Mr. Jia Ming Tan is also there with us. Welcome from Singapore.
Yeah.
Please ask him to put on a smile. He's looking too serious.
Yeah.
Okay.
Thank you, Dr. Sethi. I've seen a lot of familiar faces. It's nice to, meet everyone. So I'm going to introduce JM, who will go through a small presentation,
please share your
and then
slides
I'll come
also.
back on there. JM, do you want to take over? It's a solution to the capacity challenges we have.
Hi everyone. Are you guys able to hear me?
Yeah.
All right, sounds good. Thank you so much everyone for taking the time again today. My name is Jam and I'm the co-founder of Moon Technologies. So thank you so much for Dr. Arun Sethi's invitation and also from the Healthy Eyes team, Padi Rasita, and for the support here. So I'll be sharing with everyone in regards to our device that we have created. I think some background on what we do. So what we are doing is actually building the world's most comprehensive, self-administered and ultra-portable ocular screening device. So a little background is that I come from a family with certain ocular disease. So my mom has glaucoma and my brother is born blind. So I've actually witnessed all the disabilities that they actually face on a daily basis. So that really set my team and myself out there to really create a device to screen for all these diseases as early as possible. So the mission of the team is to eliminate preventable vision impairments and blindness. So more information about us, which is that we are funded by the Singapore government, and we recently onboarded Taiwanese investors such as AppWorks as well. And of course, we have some private venture capitalists that are on top of our company as well. So I think the key thing here, and of course, I do not need to really speak so much about this, is that 900 million vision impairments are actually preventable globally. So we built our device based off three big pillars. The first one is that we have to acknowledge that eye diseases, they are usually asymptomatic. They usually don't show signs of symptoms. And when they actually find out that they have these eye diseases, it's actually usually too late, and they are unable to reverse some of the loss of sight due to the condition. And the second pillar here is about the healthcare providers. So ophthalmologists, optometrists, or technicians who are in charge of actually diagnosing or screening of the patient, there's actually a huge reliance on human examiners to do that. So what it really means from the hospital standpoint is that the throughput is actually really limited, as it is real manual work to conduct all these tasks for the patient. And I guess the other important point is about the real estate. So meaning to say that huge diagnostic machines are actually required, and there's always a limit to how many machines they can actually put them on. So this and lastly is from the payer's perspective. Globally, especially if you're suffering from any especially in regards of vision impairments, there's actually 411 billion of economic burden from vision impairments and blindness alone. So we built our device based off these three big problems. It must be a device that can actually benefit these three groups of whether it's payers, ophthalmic providers, or patients, for this. So, and this is what we have developed over the past 7 years. It's called GLASS, and it is quite simply a device that's able to stratify ophthalmic risk really quickly. So it's made out of a high resolution display. There are advanced Qualcomm AI chips inside and multi sensors that can also capture the structural images of the eyes. And by using the display, we're able to actually run multiple functional tests on the device, and it's designed to be ultra portable and self-administered. So you might be wondering, so what kind of tests are we able to conduct? So the way we look at it is, if we are already creating a device that's so powerful, that's able to screen for so many diseases, how do we really think of it? Um, um, the main thing is that we started off with ETDRS visual acuity, which is everyone here will know that that is the very first test that any patients with visual complaints will do. So we have that, and we started onboarding and developing new tests like AMD, and that is done through vernier hyperacuity tests, glaucoma visual field tests to actually diagnose for it, and also using the cameras on our platform, on our hardware platform to actually capture like cataract or diabetic retinopathy. And of course, we run all these trials in Singapore. So I think just for everyone's knowledge, this is a sample point of view video if you were to actually use it for ETDR's visual acuity. So let me just take everyone through it. So you'll be able, if you wear the device, this is literally what you see. And of course, we start off with left eye or right eye. And once the test begin, you can just literally call out KDHSV. And our speech to text recognition system will be able to capture. So it display the optotypes from the largest 660 all the way to the smallest 66. So what is important here is that we spatially manipulate these optotypes as though as they are actually indeed 4 meters away. So this is equivalent to the gold standard of ETDR's visual acuity alone. And what's best is that this is done in a self-administered way. So no technicians are required in the process, and no additional testing lanes or space will be needed to conduct this test. So one of the trials that we have done is actually in Singapore, Tan Tock Seng Hospital. So I think what's really important is for most places, they actually use Snellen charts, and we decided to really capture the gold standard, which is ETDRS logMAR charts here. So in Singapore, on the left side of the table, we can actually see that, yes, this is a labor intensive test as compared to the Snellen chart. Usually it takes 5 to 10 minutes. And of course, there could be one examiner conducting the test for the particular patient. Okay. And of course, these tests require either 4 or 6 meters physical space. And the examiners will actually record and calculate the patient's test results in logMAR style and manually. And by using our device, they can actually automate the entire thing. So the patient literally put on the device and they are able to actually conduct the ETDRS. So similarly to the video that I've showed you guys earlier, optotypes will be in front of the patient. They simply call out what they see. And using the speech to text technology on the device, you're able to capture everything and calculate the entire logMAR score results and send it to the patient or ophthalmologist if required. So this test that we have done again in Tan Tock Seng, Singapore, just for everyone's knowledge here, we conducted a 380 patients trial to actually measure equivalence. I think what's really important is that for the gold standard for these charts, In order to declare a solution as equivalent, it got to be plus minus 0.1 logMAR score. And what's beautiful about our device is that we have shown it to be equivalent amongst these 381 people. For example, this trial, as you can see from the charts, for both the left eye and right eye in the best corrected way, most of them are actually within the threshold of equivalent. So more about our trial is that we have found out what is the mean difference. The way that we conduct the trial is that there'll be 3 times, meaning to say that we actually take the test, the patient actually takes the test 3 times on left eye or right eye, and we calculate the mean logMAR score difference in the best corrected way to find out what is the actual scores. So we repeat that the 3 times on the traditional chart and compare it 3 times again on our device. So that's how we actually calculate the mean difference. And whether is it standard deviation as well, we have actually showed that it is 0.08 logMAR for both eyes. And the limits of agreement is plus minus 0.16 logMAR for both eyes, which actually shows great test and retest variability. So this is a very consistent solution for the ETDRS VA as well. So and what's more is that from our trial results, we are also able to find out the test and retest variability in such setting, and it's also again within 0.1 plus minus 0.1 logMAR, and that's really important. So in the coming years, we are actually traveling to different hospitals to really actually just put this device actually to manage their patient workload, increase their throughputs, especially ETDRS VA is the first test that patient with vision complaints will do. And even if you're diagnosed with other disease, you still want to know their logMAR score to see whether they are progressing in terms of their disease or actually really managing these diseases really well or not. So I know I talked about the device being able to conduct all these tasks, and I have showed you guys on ETDRS visual acuity. But I think one important aspect for everyone to understand is that in the end, we are a hardware platform, and we incorporate the best apps all over the world for other tests as well. So whether is it visual field test, yes, it can be conducted on our platform in the self-administered way as well. And we are also working with AI software that actually take retina images of patients. We work with such software developers as well and capture all these retina images using our platform. So this is one which is glaucoma, which is done.
For you detect a light.
So this is how the barometry test results will be shown after using our device, of course, using the visual field test. And these are the visual acuity results that will be shown on the dashboard. And also other areas like Amsler grid test. There's on our device as well. There's done in the self-administered way. And also using our eye tracking to actually do all these other tests as well. So the other thing is that I've shown you guys on some of the different functional tasks that requires inputs from the patient. And of course, we use the gold standard test to do that. But there are also more things, especially I mentioned about the structural images of the eyes that our device can capture. So this is one photo that is already taken from the existing device. These are ocular surface images, and we are actually building cataract screening tests using these images to really find out on early cataracts or mid-stage level or even late-stage cataract in a self-administered way. And through these ocular surface images, we're also working with clinicians because there's some ophthalmologists, they are actually interested in calculating quality blinks. That can be done as well. We are actually developing it to see whether we can actually see whether there's close relations between quality blinks and dry eye. So I thought that is an interesting topic using the same images such as these ocular surface images that we are already taking from a device. So, of course, we have all the upcoming product features, the base hardware device really up and ready, and we are working with different consultancies to actually get the registration of the regulatory in different countries. I think what's really important is, first of all, which is the fundus integration and having a self-administered retina images will be extremely powerful and actually streamline tons of processes. We are also adding things like the tunable lens. So what are tunable lens? In fact, some clinicians, they actually ask me, which these are lenses that actually by using some of the that's able to change based off what refractive error the patient is actually that the patient actually has. So what it means that for all the tasks that we are conducting on the device, we will want to do it in the best corrected way. I mean, that's obvious, right? Because we want to eliminate poor scores due to refractive error. So our device will automatically change, and of course with available data. For example, what we're doing is actually connecting into the Singapore's electronic health records. So we will pull the refractive error data, for example, -2 and -3 on left and right eye with this level of astig, and it will change on its own within 5 seconds, and the patient can actually do the test on itself. So this is also an important tool because refractive error, we know, is still quite a huge issue, and getting accurate ones sets the tone to what test that you will be conducting, and most people still actually do not have the most accurate refractive error scores yet. So at the background, there is also an AI optometrist that actually listens, instructs, and also advise patients on whether they are wearing the device properly. So this actually increases the self-administration capabilities. So if you guys are ever in Singapore, I would love to actually have the device, let you guys try it. We are ready to actually demonstrate at any point in time. So yep, the most it sounds like this is a dream come true, especially we can actually improve so much of their workflow. But this is ready. This is a device that is already ready. So we are working with all these tier 1 customers, and we are just proud to really showcase this. Thank you so much again, everyone.
Thank you, JM. That was a really good
I must say, a very
presentation.
useful device, especially for the developing world and for those who are doing mobile eye care clinics. What's your opinion, Dr. Munish Patel, about this? The other thing I want to know is that would this work in the basis of an app? Do you think you can create an app and use this kind of a thing that would be even more remote than having the instrument on your head? If we could do a work like we're doing so many things, and can we do it virtually, like we're doing this webinar using your equipment or something similar and getting the same kind of accuracy? Are you working on that?
Yes, we are. So one thing that we realize is that because it is a headset that you're wearing on top of your head, and what this does compared to like tablets or smartphones is that we can actually with pinpoint accuracy manipulate all these stimuli, whether it's the optotypes, visual field stimuli, in a equivalent way as with the gold standard as what we are using now in the clinics or hospitals. And there's something that the tablets or smartphones, they really can't emulate. right? So this is a new class of device. Of course, there will be tons of education that we have to actually tell to the industry, but that is something that we can do that really sets us apart from tablets or smartphones.
Excellent. So with that, Pradeep, any comments? Dr. Manish, any comments? Then we move on.
Nothing from my side.
What about Madam Pradeep Grewal? You're muted, ma'am.
Hi, I just lost you there. Thank you, Jem.
What are
Thank you
your
very
comments?
much.
Anything new being done apart from this in glaucoma?
No, this is the exciting. We'll be using it for diabetic eye screening as well. There's loads of exciting developments coming in with this. We hope to be back in India in March, and we will have the update by then.
Sure. As a matter of fact, we have Dr. Meenakshi Dhar joining us. Dr. Meenakshi Dhar is also a glaucoma consultant and would be happy after the webinar to have a word with Pradeep, who's up in Cayman Islands with Aditya and Saiba, where she's doing a lot of work in glaucoma and with Mr. Tan on the virtual device, which you just missed. So over to Dr. Meenakshi, Professor Meenakshi Dhar from the Amrita Institute at Faridabad, the largest hospital now in the country in the private sector, where she runs the ophthalmology department.
Hello. It's a pleasure to be here, and thank you for Dr. Arun for making me, and Dr. Reena for making me a part of this wonderful session. And without much ado, I'll go on to sharing my slides. Give me a minute, please. Can you all see it? Can you hear me, please?
Yes, we can see you, we can hear you. Please carry on.
Hi.
But we can't see Dr. Puneet Dhar now.
Oh, you'd like to see him? Okay, there he is.
The tech support.
Okay, coming on to glaucoma masquerades, we'll start with this little story from a patient who came to us from Africa, and he had a total visual loss in the left eye, and his right eye was normal. He was being treated as glaucoma for his high IOP, and he was actually an ophthalmologist. And when we did the peripheral field, there was a peripheral field loss as well. But when we looked at this, they were large. There was a deep cup. There was a high CD ratio. But also, we see that there is a pallor there on the temporal aspect. So we went ahead and we thought of doing an MRI. And what we found was that there was a pituitary macroadenoma extending into the paracellular region and compressing on one of the optic nerves much more, because maybe it was a post-fixed chiasma and leading on to more effect on one eye rather than the other. So we have to be very careful when we are diagnosing patients, and the mimickers of glaucoma could be in their symptomatology, a painless visual loss, or it involves the periphery in prior to and more severely than the central vision, like in compressive optic neuropathy. Or it could be that the signs, the high IOP, optic nerve head changes, or the visual field defects can mimic the changes in glaucoma. And when we are talking of high IOP, we should see whether is it repeatable, what is the history. The patient could be taking steroids for allergies, etc., or it could be post-surgical silicone oil, or may have had a triamcinolone depot. And taking IOP as a routine screening is a good practice, and do the aplanation is the better way to go. Now, these patients could be steroid responders, could be having ocular hypertension, could be having we found that patients who used to come for their full health checkup, when they came to us, their IOPs were high. And we thought of doing a glaucoma workup for them. And when the second time they came over, their IOPs were normal. Then we later realized that all these patients used to actually be having copious amount of water so as to get their ultrasound done. And it was actually that was the fluid overload was causing a high IOP, and they were otherwise normal. So also a high episcleral pressure, compressive optic neuropathy, thyroid exophthalmopathy, topiramate-induced angle closure, Posner-Schlossman syndrome. All these things need to be kept in mind. So when it's a steroid responder leading to a high OP, we should take a good history. These patients are usually asymptomatic, and the IOP very often decreases on cessation of the steroids. And in a small portion of these patients, they take the same course as a primary open-angle glaucoma. So taking a very good history, especially a drug history, and trying to remember the different routes of steroids that the patient may be consuming is very important. Ocular hypertensives, as the definition goes, the IOP is high, but they have normal fields, normal optic nerve heads, normal OCT, and there is no progression over 3 years. Although in the glaucoma trials, it has been found that if the patient has, say, optic nerve head hemorrhage, it may be followed up in cases over the next 5 years with a nerve fiber layer defect in that particular area. Topiramate-induced bilateral acute angle closures present as painful sudden visual loss, occurs in otherwise normal eyes with normal anterior chamber angles which are open. So in these patients, the patient comes with blurring of vision which is bilateral. There is one will see a shallow anterior chamber. It's a good idea to always do these, even if they can't see, to do their auto-ref, and you can see that they seem to have myopia because of the anterior displacement of the lens iris diaphragm, and then there is the rotation of the anterior rotation of the ciliary body, and this occurs. And in these patients, if just once stops the drug, gives a topical and oral aqueous suppressant for that time being, and give topical cycloplegics, and the patients return to normal, get good vision. So it's important to take the history of whether the patient is having migraine and what medication the patient is for migraine. And pilocarpine is contraindicated in these subjects. Compressive optic neuropathy, whether it is because of a thyroid exophthalmopathy, can also lead to a rise in eye pressure, IOP. So it has been found there are multiple ways by which in thyroid exophthalmopathy, the eye pressure may rise. It could be because of an increase in the intraorbital pressure, which happens because of the proliferation of the intraorbital connective tissue, enlarged and swollen extraocular muscles, and the increase in the intraorbital fat. It could also happen because of an increase in the episcleral venous pressure, which is secondary to the orbital congestion, or increased mucopolysaccharide deposition in the trabecular meshwork. Also, it has been found that there is a direct thyrotoxic effect, which can cause an increase in the IOP. And there is generally a genetically linked predisposition to thyroid disease and glaucoma. And this was first described by Wesley in 1918. So it's been all around for a long time. This was one of our patients who had thyroid. He had high IOP and a restrictive myopathy. And this can always be elicited by doing the Braille's sign, in which we take the eye pressure in straight gaze and in up gaze, and there is a rise in IOP by at least 8 mm. These patients have arcuate or double arcuate sclerotomas, may have an optic nerve head pallor, and the OCT is indistinguishable, but it is a reversible condition. And this is one of my patients who did have a decrease in the ONH parameters, and there was an inferior RNFL thinning. This is way back in 2005, and it was presented in one of the international meetings as well. So this is one of our patients who had a bilateral. 1 second.
Dr. Meenakshi, your slides are not moving on the screen. The technical team to please help Dr. Meenakshi.
Can the technical team please stop sharing and then we can reshare?
Dr. Manish, please ask the technical team to do the needful.
Himanshu, can you please look after the issue? Himanshu? Ma'am, please give us a second.
Shall I come out and then do it once more?
I think come out and then do it again.
Yeah.
Ma'am, I think you can reshare again.
Yeah, I'll reshare. So did it not move from the beginning? Shall I
Yes,
start?
ma'am. Yes, ma'am. It did not move from the beginning.
Okay, fine. So maybe I will just.
The last moment, I think it was the last slide we could see just a while ago.
This one. Now, is it sharing or it's not sharing?
No, ma'am, it's not sharing.
Okay, 1 second. 1 second. 1 second. Is it sharing now?
Yes, ma'am. You are now visible.
Yeah. I will try to play it. Is it moving now?
Ma'am, can you please go on to the next slide? We'll just check.
Yeah, next slide. Then we
Yeah,
know
yeah.
whether they're moving around.
I'm on the.
Now?
Yeah, now it's okay.
Is it okay?
Yeah,
yes, ma'am.
total visual loss from Africa.
So shall I? Is it moving now?
No, ma'am, it's not moving.
So shall I? Shall I play it like this only then? One second. One second.
Meanwhile, can we have Dr. Saroj Sahadev? If you have any questions to ask about the same topic, ma'am.
Okay. Is it sharing now?
Yes, it is seen, but the first slide is only seen.
Yeah, I'll just see whether it moves.
Ma'am, you can maybe try by sharing your
now
entire
it's moving.
screen.
Now it's moving.
So
Ma'am, I think manual would be better than just the play button.
Yeah.
The slide
Now is this better?
Yes, ma'am.
Yeah.
Now it's working. Now it's okay.
I'm so sorry for that.
No, perfectly all right.
Yeah. So we'll restart. Should we restart?
We can go to the slide you were talking about.
Okay. So
like further on. Yeah, this one. Ocular hypertension.
Okay.
Yeah, from here.
So ocular hypertensives have normal fields, normal optic nerve heads, normal OCTs. They do not show progression, and the eye pressures are only high. And only when we do a full glaucoma workup will we be able to differentiate between these patients and patients of glaucoma. Although it has been found that if there is an optic nerve head hemorrhage, these patients end up having a nerve fiber layer loss in the next 5 years. Topiramate is a medication which is used for migraine, and that can produce bilateral acute angle closures with very high IOPs. It occurs in patients with otherwise normal eyes with normal anterior chambers. This will present as a bilateral blurring of vision, and one finds that there is a high IOP, there's a shallow AC, and although the patient may not be wearing glasses before, on the autorefractometer, it can be seen that they have a recent onset myopia of around 2 to 4 diopters. What happens in these patients is that there is an anterior displacement of the iris lens diaphragm with an anterior rotation of the ciliary body. And these patients are to be managed with topical and oral aqueous suppressants. The drug, which is being the topiramate, should be stopped in consultation with the physician, and topical cycloolytic agents lower the IOP by retracting the ciliary process back. Pilocarpine is contraindicated in such patients. Coming to a compressive optic neuropathy in patients of thyroid exophthalmopathy or with orbital apex syndrome, there can be a rise in IOP which occurs because of an increase in intraorbital pressure, which happens because of the proliferation of intraorbital connective tissue, enlarged and swollen extraocular muscles, and increase in the intraorbital fat. Also, these patients
Ma'am, you're not audible.
You're
Am
not
I audible now? Am I audible now?
Yes, ma'am. Yes, ma'am.
Yeah, increase in the mucopolysaccharide deposition in trabecular meshwork, or with the direct thyrotoxic effect. These patients have a genetically linked predisposition to thyroid disease as well as glaucoma. This condition was first described by Wesley. These patients, this is one of our patients who had an orbital apex syndrome with a high IOP as well as a restrictive myopathy. In these patients, one points that there is at least an 8 millimeter rise of IOP when taken in upgaze, the Brayley's sign. These patients will have visual field defects and of double arcuate or arcuate scotomas, optic nerve head pallor, and the OCT is indistinguishable, but it is reversible once the thyroid levels come normal and the exophthalmopathy decreases with the use of steroids or radiotherapy. This is one of our patients who had a bilateral severe proptosis with high IOP. After treatment with steroids and radiotherapy, one can see that the visual fields have become perfectly normal. So when we are differentiating between a patient with compressive orbitopathy and open angle glaucoma, the visual acuity, there is a hyperopic shift in compressive orbitopathy. There are less hues dyschromatopsia. There is an RAPD. There is a decrease in the outflow facility, improves with hypothyroid treatment. This could be swollen up, or could show atrophy, and optociliary shunts may be present. The field loss could be a centrocecal scotoma, which is baking into the periphery. The blind spot may be enlarged, or there may be a constriction of fields, the visual fields temporally, and inferior loss is seen. Also, these patients respond to steroids. The visual field defects are reversible, and this can be seen on the crowding of the apex on CT MRI. And the VEP may be abnormal with a prolonged latency of the P100 component. The orbital decompression and extraocular muscle surgery lowers IOP in these patients, as proven by these some of the articles which have been published on this. Now, the arcuate visual field defect can also be seen in a branch retinal vein occlusion. And so one should not, when one sees an arcuate visual field defect, do not miss out on doing a good ophthalmic fundus examination, and this will not be missed. Optic pit, again, there's a unilateral solitary gray-white excavation in the infratemporal quadrant, which projects as a superior arcuate scotoma. These scotomas are non-progressive, and this is because of the complete closure of the superior edge of the embryonic tissue. These patients have normal IOP, and they may end up having a neurosensory detachment or retinoschisis, and the diagnosis is based on OCT. Their pits may be associated with the neurosensory detachment, and the horizontal line scan, one can see that there is a pit seen on the horizontal aspect of the cup. There may be cystoid changes and schisis cavity formation in the peripapillary retina, and there may be a serious macular detachment communicating with the optic pit. Most often, these patients are asymptomatic. There could also be an acquired pit of the optic nerve, in which you see a deep localized excavation of the neural rim with sharply localized depression and loss of normal architecture of the lamina cribrosa. And there is an inferior optic disc. The visual field loss is very close to the fixation. It is more prevalent in low pressure glaucoma than in high pressure glaucoma, and in high myopia. There's an increased risk for progression of the optic disc damage and visual field loss. Again, colobomas, which is the typical coloboma, also produces a superior arcuate scotomas, which again will be non-progressive. And the RNFL, they will be having a decrease, will be decreased in the inferiorly. And one can see on examination that there is a coloboma. And in morning glory syndrome, it's a rare congenital anomaly where the vessels seem to arise from the disc, the funnel-shaped optic nerve head. There's an elevated ring of pigment around the disc, and this happens because of mesodermal dysgenesis. In patients of ocular ischemic syndrome, one sees a high CD ratio, a deep cup, extensive field loss with normal IOPs. On the OCT is indistinguishable. There is an RNFL loss, and it's the history and the normal IOP and will make us clinch the diagnosis. If the patient has, and doing a carotid Doppler will help us find out the carotid artery stenosis. These patients may be bilateral, and we should, whenever we are suspecting that it's and before labeling a patient as a normotensive glaucoma, it's good to do a carotid Doppler. This is one of our patients who had a ocular ischemic syndrome, and one can see that there is a decrease more so in the right eye. On the OCT, there is RNFL thinning. AION leads to a unilateral visual loss and an arcuate scotoma, which is actually, one should be able to differentiate between an altitudinal scotoma and an arcuate scotoma. And these patients have a small pale disc with a small cup. And there may be a history of peripapillary papillary edema in the immediate period, but in the late stages, it may be it may just show up as atrophy. So in the acute phase, one sees a gross elevation of the disc, which is clearly evident on OCT. The RNFL is normal or increased in the acute phase, but later it decreases. This is one of our patients who had a left AION, and one can see the disc is edematous, and which is totally with a superior arcuate scotoma. But this would one never would confuse this with a glaucomatous disc. And one can see that the RNFL and ONH parameters are both increased. This is another of our patients now who had a biarcuate scotoma, and the patient, this one can see that there is no, it's a small disc with a small cup. So visual fields, one differentiates between a neurological visual field defect and a glaucomatous field defect by noting that neurological field defects, apart from altitudinal, generally respect vertical midline, and the glaucomatous respect the horizontal meridian. The neurological field defects are central, paracentral, altitudinal, and a nasal half is rarely involved. And it is the nasal half which is first involved in glaucomatous patients. Now, this is the classical, we are very used to seeing this photograph, and we know that there, depending on which part of the optic nerve pathway is involved, you can have various types of scotomas, and which the scotomas are both localizing and lateralizing. This is one of our patients who came, was referred from the neurology department as a patient who came with only PL, and it was referred to us as optic neuritis for fundus evaluation. Both eyes had RAPD, the angles were narrow, IOP was high, almost 55. We realized that it is an angle closure rather than and we did a PI, the patient's IOP decreased, visual acuity improved, and the OCT, since it was caught early, was stayed normal. So to summarize, the group of patients can be divided into either those which are the mimickers because of high IOP, the mimickers because of visual fields, and the mimickers because of the optic nerve head changes. One should look at the disc pallor and at the cup disc ratio. In the visual fields, the arcuate scotomas can be present with optic pit, BRVO, compressive optic neuropathy, coloboma, optic nerve head drusen. And bilateral arcuate scotomas can be in ocular ischemic syndromes. Binasal scotomas can be present in very, very large pituitary tumors. Altitudinal defects are seen in AION, optic disc coloboma, and ONH drusen. Now, and OCT helps us in diagnosing the optic PIC, optic nerve head drusen, and in AION. And the non-glaucomatous cupping present is seen more often in people with less than 50 years. Optic disc pallor is an excess of cupping. Field defects that border on vertical meridian. Gross asymmetry of damage is evident by visual fields, OCT, and vision loss. Thank you. Glaucoma management is a lifelong thing, and we should include the indicators before labeling it as glaucoma.
Thank you very much, Professor Meenakshi. Very well illustrated, very informative, and very detailed. One of the best presentations we've had in optic disc. Thank you very much. Any questions from Dr. Patel?
So nothing as of now, I think. If
So,
Dr. Saroj,
we move on to the next speaker. And Dr. Meenakshi, thank you for coming back and catching up at the last minute. Very sweet of you.
Thank you. Sorry, there was some misunderstanding. Thank you so much.
Kindly moderate the next two speakers also.
Yeah, I'll be there.
Dr. Saroj is there. You can ask her to join.
You are not audible, ma'am. You're not audible.
You're muted. So Professor Dr. Saroj will now be joining us and giving us our talk.
Ma'am, you are unmuted, but you are not audible.
Hello.
Yes, ma'am, now you're audible.
There's one speaker left right now, Dr. Sai Baba Gaur. I don't have a talk. I'm the moderator.
Okay, so Sai Baba God is left.
Yeah.
So
I think
sir
he's
has not joined as of yet, sir. I think only sir is left, and Dr. Kanwal is left.
No, Dr. Kanwal has not left. He's got a recorded speech, so we'll ask him to present that. Could the technical team please present Dr. Ken Nischal? Kanwal Nischal, the president of the Pediatric Ophthalmic Society. Technical team, please come in. It's a recorded speech. So I think with that, what we'll do is we'll have this speech uploaded so we can see it later. And with that, we call it the rest day. And thank you very much, all the moderators, for helping us when we've had more than 2,200 audience across all the 9 halls, which has been a landmark for us across globally. And we thank Dr. Meenakshi and all of you for joining. Good night and a happy day for you.
Thank you so much.
Pradeep from all the way from Cayman Islands.
Thank you.
Thank you.
Good night. Please
Take
put
care.
your comments
Thank
in
you
the
very
gallery
much.
before you leave.
Bye-bye.
Thank you.
Thank you. Bye.